एक मिनट, we'll have to airdrop it. Hello everyone, and due to rain we had some technical issues, and that is why we got delayed. Sorry for the delay. Now we will be starting today with the F.I.R session again, right? So let us start. So now we are starting, guys. Just have a look. So for we are starting by the obstetric part, right? सबसे पहले, the first of all, what we are going to notice is oocyte count across different life stages. They have asked you, right? So the most of the oocytes, they are formed in the ovary during the intrauterine life, right? 20 weeks of the life when it is actually a fetus. The count is 6 to 7 million, right? In the intrauterine stage, and at birth, what happens? The approximate oocyte count is 1 to 2 million, right? And when the person or the female reaches the puberty, the number of oocyte, they keep on degenerating and ultimately reach to 3 lakhs to 4 lakhs, right? So, and at the end of the menopause, nearly at the end of the menopause, the oocyte count decreases very much, and it nearly reaches the value of approximately to the 1000. Some books also writes 400 to 500 oocytes or something like that, but it's okay. Approximately 1000 values you will have to remember. They don't ask this much very much. Most important thing that they ask you is, in the fetal the intrauterine life, you have 6 to 7 million oocyte count by the 20 weeks of IUL, and at birth you have 1 to 2 million, right? And by the time you reach the puberty, or the female reaches the puberty, the oocyte count reaches to 3 lakh to 4 lakh, right? Now come here, what are the keynotes, important points, what they can be asked in the question? So keynote here is, the count of oocyte declines significantly due to atresia. Most common atresia. What is atresia? Naturally degeneration due to radiation damage, due to other factors, right? Chemical damage or any other factors damage, there will be natural atresia or decrease in the number of the oocytes. Second thing, only about 400 to 500 oocytes are ovulated during the entire menstrual life cycle of a female. In a female, suppose she has a menstrual age, she starts puberty by the age of average is 12.5 years, right? By the age she reaches 50, she starts having menopause. So in this entire duration or the life cycle or reproductive life cycle, a female generally ovulates, only uses about 400 to 500 oocytes, right? Now menopause count can be variable, I have told you, but is much lower than the previously started, near to approximately, you can call it 1000 or something less than that. Now the trophoblast generally has two forms, the cytotrophoblast and the syncytiotrophoblast. You can look from the image very clearly at the cytotrophoblast, the cells arranging here, the cells, the cellular shape, they are the cytotrophoblast, right? The syncytiotrophoblast here, and this structure. Now cytotrophoblast, generally they have asked you about the location. So location is the fetal side of the placenta, and the role it contributes to the formation of chorion frondosum. Important point, right? That is the functional part of the fetal placenta. Now, how to remember? C for cytotrophoblast, C for chorion frondosum, right? And C for and forming the part of the fetal placenta or Chotu's placenta, right? From the trick you can remember CCC. Even if you forget, they have asked you many times. So chorion frondosum, cytotrophoblast from Chotu's. Chotu is the fetus, right? Chota fetus. So fetal part. Now coming here to the syncytiotrophoblast function, very important. They have asked you. They are responsible for secreting HCG hormone and responsible for secreting HPL, human placental lactogen. These two importance they have asked very commonly. And this HCG, what is the role of HCG? They have asked you for maintaining the corpus luteum, right, and promoting the fetal growth. Now, come here. Important, all the important points, whatever they've asked, we are discussing here. Now, coming to the placenta, its structures and its features. See, again, the maternal side of the placenta, they have asked you the question from where it is derived. It is derived from decidua basialis, right? Maternal contribution to the placenta. Now, how will you remember? See, CCC, chorion foundation, they have asked, right? Syncytotrophoblast, you know, responsible for secreting HCG and HPL. The maternal side of the placenta, whereas is derived from MD. MD, maternal side derived from decidua basialis. Done. Now, generally structure, how is it? Generally, it is composed of 3 to 4 lobes. Each lobe is further divided into 15 to 20 lobules, right? Known as cotyledons. Now, cotyledons are actually the functional unit of placenta. The most detailed question they can ask you about this is that cotyledons are the functional unit of placenta, right? Bus, where maternal fetal exchange takes place. This is not frequently asked in FMG exams. For your exam level, only this question, the maternal placenta derived from decidua basialis. This is important. Regarding the chorion frondosum, what I discussed is important, right? And regarding the cytotrophoblast, it is important. And regarding the syncytotrophoblast, these 3 points are important from FMG point of view. Just you have to remember this and nothing else. Your exam point and level is covered. Come here to the half-Burr cells, right? So what is happening here? They are specialized macrophages present on the half-Burr cells. They have asked you about specialized macrophages. Since they are macrophages found in the chorionic villi of the placenta, macrophages, what will they do? Immune function, but simple, immune regulation and fetal protection, just nothing. Macrophages present in the chorionic villi of placenta, half-Burr cells. And what is their function? Their function is immune regulation and fetal protection. This question can be asked in the form of gynae question, also in the form of pathology question. Now, coming here to the types of placenta related complications. See, from the placenta, we know a lot of complications are arising. So now we will be discussing them one by one. Every topic, every MCQ point will be covered. Have patience, patiently sit, and we will be revising conceptually every topic, right? So, starting here from the antepartum hemorrhage, right? Antepartum hemorrhage, you know, defined as bleeding from the genital tract after 28 weeks of gestation. And what is 28 weeks of gestation? They have asked you many times. It is actually once the fetus crosses 28 weeks of gestation, it is called as the period of viability or the age of viability, right? Now, causes of antepartum hemorrhage. Many causes, among them the important ones we will be discussing. Antepartum hemorrhage, the cause can be placenta previa. The cause can be abruptio placenta. What is placenta previa? You already know. The placement of placenta in the lower uterine segment. What is abruptio placenta? Premature separation of the placenta or the normally implanted placenta, right? What is vasa previa? The vessels, the blood vessels, when covering through the going and passing through the os, right? They will call as vasa previa. Now, local causes can be there. There can be cervical polyp, there can be erosion, there can be malignancy. Now, come here to the next topic, bleeding. For bleeding, you already know more than 28, up to 28 weeks or more than 28 weeks until delivery, right? That is antepartum. Now, painless bleeding, how will you identify the question? Now, I will not only teach you, but I will also tell you how to identify in the question, how what are the topic they have asked. Very simple, listen to the approach very carefully. See, if they give you in history or the question, there is painless bleeding, right? And now, look at the characteristic. If the bleeding is recurrent and painless and causeless bleeding, that is bright red in color, right? So, associated condition should be placenta previa. Simple. In placenta previa, the bleeding will be painless, causeless, recurrent, and bright red color. If in the question they give you this kind of history, it is classical indicative of placenta previa. Now, the reason we have already discussed what is placenta previa, location of placenta in the lower uterine segment. If they give you in the history of painful bleeding, then what you are going to do? Look at the characteristics. If it is associated painful bleeding, abdominal pain के साथ में, and that painful bleeding is dark red in color and non-recurrent, एक बार होगा, that means they will give you the bleeding history एक बार होगा, dark red color का bleeding will be there, right? Non-recurrent type, बार बार repetitive नहीं होगा, then you have to guess or doubt for abruptio placenta. Every topic we will be discussing. First of all, we are discussing first of all क्या? So we are discussing the approach to the question, how to decide whether it is a question of abruptio placenta, how to decide whether it is a question of placenta previa, right? After that, we'll be discussing the topic as well. Now, come here. So, here you have the common causes. What are the common causes? See, pregnancy induced hypertension, one of the most common causes of bleeding, right? Painful bleeding, and other cause of bleeding. Now, trauma, folic acid deficiency, smoking, cocaine use, and polyhydramnios, they can also be the common causes for bleeding. Coming to the individual topic, that is placenta previa. I already told you in placenta previa, the bleeding will be of, batao, it will be recurrent bleeding, causeless bleeding, and bright red in color history के साथ आएगा. So other clinical features, what will be there? Just have a look, guys. The other clinical features will be height of uterus corresponds to the period of gestation. Now, uterus is soft and non-tender in nature. What are the fetal heart sounds? The fetal heart sounds here will be if they are clearly audible. In the pervaginal examination, you will see it is contraindicated. Why? Because there is risk of triggering severe bleeding. I told you placenta is located in the lower uterine segment near to the os. So if you are doing pervaginal examination, there is high risk that you may damage or cause tear to the placenta or part of it and tear to the placental vessels, and this can trigger severe bleeding, right? So pervaginal examination is contraindicated. This is an MCQ point, important MCQ point if you suspect placenta previa. Just pay attention to it. Now, come here, guys. Investigation of choice. If they ask you for placenta previa, it will be transvaginal scan, right? Now, management. See, placenta previa has different types, first of all, and depending on the type, you decide the management. You already know in type 1 and type 2 type 2 may be basically the anterior type of the placenta. They are managed by normal vaginal delivery. These are all MCQ points. They have asked you if the placenta previa is type 1 type and type 2 anterior type, they are managed by vaginal delivery. But major degree placenta previa mein, you will have to go for C-section. You cannot go for normal vaginal delivery. And what are the major types? Just have a look. You have the type 2 posterior placenta and the type 3 and the type 4. Completely they are requiring C-section. Right, guys? Now, Dr. Jatan Rana, they are asking English. Sir, somebody has to. Sunil, sir, आपने यूक्रेन से MBBS की है? नहीं, I have not studied from Ukraine. It's okay, fine, but let's not discuss this kind of things. क्योंकि let's ask productive question, कोई doubt हो तो, otherwise the productive questions get lost, right, guys? Chalo, come back. Now, coming to the stall-worthy sign, they have asked you, this is observed generally in the posterior type of placenta previa. Important question point. Now, they will ask you the management. How will you manage placenta previa? Come here. Here you will see the conservative management approach, right? The first conservative management approach, there is a named regime called as McAfee-Johnson regime. But here you apply the wait and watch approach until the fetus reaches 37 weeks of gestation. Now, if I told you where will you try for normal vaginal delivery, type 1 and the type 2 anterior type, तो यहाँ पर you will apply conservative management approach, McAfee-Johnson regime, very easily. Just wait and watch until the fetus reaches 37 weeks of gestation. So, no active bleeding is there, maternal vitals if they are stable, gestation less than 37 weeks or up to 37 weeks, and no signs of fetal distress is there. You follow the conservative management. And they are the indications, right? What is the protocol for the McAfee-Johnson regime? Just admit the patient, hospitalize it. Now, you will have to deliver administered corticosteroid injection for fetal lung maturity if the fetus is less than 34 weeks, right? Gestation period, and you have to plan for delivery. If fetus is less than 34 weeks, then you will have to administer corticosteroids, right? For Rh negative mother, you will have to administer anti-D, and ensure, you will have to ensure that blood is available, because in placenta previa, there will always be risk of bleeding, even it is type 1 type or type 2 anterior type, easy type also, there will be risk of bleeding, right? So you will have to arrange reserve blood always. Now, in active management, what you need to do? Active management, it is generally when it is indicated. First of all, they will ask indications. In the other way, they may give you the history, right? That they will write in the question that there is active bleeding. There's kind of indications they will write in the question, and they will ask you what will be your next best step. तुम्हारा next best step क्या होगा, right? They will ask you in this manner in the question. So now just have a look. Active management indicated for active bleeding, when the bleeding is active, the patient is bleeding actively, maternal instability and fetal distress is there. Now, delivery is taken immediately. In active management, immediately you have to go for delivery and go for what? The C section, cesarean section, right? We have discussed this. Now, I hope we have discussed the placenta previa, low-lying placenta, type 1, type 2, anterior type, normal vaginal delivery trial can be given, type 2 posterior and other types. You have to go for cesarean section. Conservative management, McAfee-Johnson regime, up to 37 weeks of gestation, you have to go for wait and watch approach, right? And beyond, and if there is active bleeding present and there is fetal distress present, then you have to go for C section or immediate termination of the pregnancy, right? Now come here to the topic of abruptio placenta. In abruptio placenta, you will see what are the clinical features. We have discussed already in abruptio placenta, the history they will give you, right? What kind of history? Bleeding, generally one episode, and dark red color clot kind of blood, right? And in this, the height of the uterus, clinical feature they will mention you on examination, is smaller than the period of gestation, right? Because the placenta has ruptured a little bit. Uterus here in abruptio placenta will be tense, rigid and tender, right? Abruption has already taken place of the placenta. Placenta का partial separation हो सकता है, complete separation हो सकता है. So according to that, you will find uterus will be tender, rigid and tense. Fetal heart sounds will be absent. Coming to the classification. So you have the classification, that the page shear classification is used for grading of abruptio placenta. We are not going to into the detail of the page shear classification, not very much asked frequently, just we have mentioned the name. Because if they ask you, the worst case scenario, they will ask you just the name. They don't ask you the page shear classification in for FMG level. So no need to revise and no need to get into that much detail. Coming here to the management. Management, abruptio placenta, bleeding is coming, patient is coming with a pain, bleeding, then immediate delivery is the primary approach, right? Complication, what is the complication? The complication can be development of DIC, disseminated intravascular coagulation, and it is, you know, it is a life-threatening complication, and DIC is a type of consumption coagulopathy. If you can revise from your pathology lectures or the pathology part, then you might be knowing that now. So what if DIC develops? If they give you in the question that the patient has developed DIC, so what will be your next step of management? See, generally you were first generally doing immediately delivery, but if patient is in DIC or hemodynamic unstable, then what will you do? You will first treat the DIC, that means manage the patient, go for the hemodynamic stability, then you can proceed with vaginal delivery only after stabilizing the condition, right? Now, test to differentiate fetal and maternal blood. They very frequently asked question and topic, right? This is how will you differentiate between the fetal blood and the maternal blood. Two types of tests they tell you. One is the quantitative test and other is the qualitative test. Very frequently asked. So one is the AB test or Singer's alkali denaturation test. In this test, what are you doing? This is the qualitative test. Remember, Singer's alkali denaturation test is a qualitative test. And here what you are doing, you are using reagent, alkali agent such as KOH, potassium hydroxide or sodium hydroxide. Done. Nothing more than that you have to know. It is a qualitative test differentiating between the fetal blood and the maternal blood. Now, Callihor-Betke test, right? Callihor-Betke test, you can name it like that. The purpose is to differentiate the fetal RBCs from the maternal RBCs. Now, this is a Callihor-Betke test or KB test, is a quantitative test. So it is helpful in calculating the amount of anti-D immunoglobulins in Rh negative mothers. So remember, this test is also important in case of Rh negative pregnancies, right? Or Rh positive cases. This or high, yeah, right? Mothers, Rh negative mothers having Rh negative babies. In this case, you have to calculate the anti-D immunoglobulin, and that is why you will use the quantitative test or KB test or Callihor-Betke test, right? Done. This helps in differentiating the fetal RBCs from the maternal RBC. Now, come here. One more question they have asked you regarding the amniotic fluid. So, amniotic fluid, you all know. Oligohydramnios. First question they have asked you about oligohydramnios. When the amniotic fluid volume is less than 200 ml, it is called as oligohydramnios. Definition is amniotic fluid volume, we have discussed, less than 200 ml. So common cause generally sometimes it is idiopathic, and idiopathic is the most common cause for oligohydramnios. Apart from that, fetal renal defects, right? most common cause for severe oligohydramnios. If there is severe oligohydramnios, we know because fetal urine forms a major component of the amniotic fluid, right? If there is fetal renal agenesis, what will happen? If there is fetal renal agenesis, then fetus will not form urine not formation or not taking place, then amniotic fluid will decrease severely in the quantity, right? So this is fetal renal defects. Now, drug abuse such as indomethacin, this is also associated with oligohydramnios. Now, coming to intrauterine growth restrictions, we know they are also one of the common causes of oligohydramnios. Leaking amniotic fluid, it can be leak, right? If there is premature rupture of membranes or PROM, right? Then in this case, there can be leakage of amniotic fluid. Once the amniotic fluid will leak, it will decrease in quantity. If it will decrease in quantity, what will happen? Oligohydramnios again, right? Now, uteroplacental insufficiency. What is it? It is due to maternal hypertension. Simple. So what are the important causes that you have to remember? I'll just tell you important drug yaad rakho, because in the pharma part they can ask you indomethacin first. Second is fetal renal agenesis, very important. They have asked you many times, right? Third is uteroplacental insufficiencies due to maternal hypertension, right? Either it is pregnancy induced hypertension or maternal hypertension as it is. Three important causes that you have to remember for your exams. They have asked you very frequently from these three causes. I am highlighting these three causes, what you have to remember, right? We will be giving you the notes. Come here. Now coming to the, you already know post-term pregnancy. You also know beyond 42 weeks of pregnancy, it will always be post-term pregnancy. So the fetal size will increase and the amniotic fluid volume will decrease. Come here to the polyhydramnios. It is amniotic fluid volume more than 2 liter. Definition you already know. Now common causes again idiopathic and fetal GI anomalies can be there, right? Polyhydramnios, if there is esophageal atresia to the fetus, duodenal atresia, intestinal obstruction, continuous vomiting, regurgitation by the fetus, right? It will also lead to increase in the amniotic fluid volume. Neural tube defect in the fetus, then also high chance of polyhydramnios. Maternal diabetes, ध्यान रखो, important thing, important differentiating point. Maternal hypertension हो रहा था. If there was maternal hypertension, then what was it? It was associated with oligohydramnios, whereas maternal diabetes is associated with polyhydramnios. ये बात ध्यान रखना, भूल गए तो कैसे याद रखोगे? वेरी सिंपल ट्रिक आई एम गोइंग टू टेल, ध्यान सुनना. डायबिटीज में क्या होता है? डायबिटीज इटसेल्फ इज कैरेक्टराइज्ड बाय ट्राइड ऑफ, यू ऑलरेडी नो, पॉलीडिप्सिया, पॉलीफेजिया एंड पॉलीयूरिया, राइट? ध्यान रखना, तो माँ को भी होगा, बच्चे को भी ज्यादा पॉलीयूरिया होगा, ऑब्वियसली, बिकॉज इफ मदर हैज हाइपरग्लाइसीमिया, ultimately fetal will also have hyperglycemia. Due to that, what will happen? Polyuria अगर fetus को होगा तो amniotic fluid volume will increase, right? So ऐसे याद रखो, अगर डायबिटीज का तुमको याद है, if you remember for the diabetes, then you can easily remember कि hypertension में उल्टा होता था, oligohydramnios. I hope I am clear, guys. Now, चलो अब आते हैं इस पर, fetal factors. fetal factors क्या क्या है? मल्टीपल प्रेगनेंसीज, एग्जाम्पल जैसे ट्विंस में देखने को मिलता है, राइट? टॉर्च इन्फेक्शन, सीधी बात, इफ यू हैव मल्टीपल प्रेगनेंसीज देयर रिस्क ऑफ देयर इज ऑलमोस्ट देयर विल बी पॉलीहाइड्रोमनस, टू फीटस और मल्टीपल प्रेगनेंसीज, राइट? ट्विंस है, ट्रिपलेट्स है, मोर यूरिन आउटपुट बाय ऑल देम, तो पॉलीहाइड्रोमनस ऑब्वियसली. टॉर्च इन्फेक्शंस में यू विल सी, फीटल अनीमिया में यू विल सी, राइट? नाउ कम टू मेडिकल टर्मिनेशन ऑफ प्रेगनेंसी, MTP एक्ट वी विल बी डिस्कसिंग हियर. दिस इज वेरी इंपॉर्टेंट दैट वी हैव टू डिस्कस. Now, come here and let us discuss this. So, in medical termination of pregnancy, what is going to happen? बहुत सारे questions आते हैं. 2 questions are एकदम fixed for in every FMG exam for regarding the MTPs. Very carefully listen to it. The legal limit, because they ask you from the gynae part of view, they ask you for the forensic part of view also, point of view also. So, 2 questions are fixed. Now, medical termination of pregnancy, you will see here. The legal limit is pregnancy can be terminated up to 24 weeks in India. You already know now. Now, for the approval, they have asked you up to 20 weeks, you need approval of only one doctor or one specialist. Up to 20 to 24 weeks, you need opinion of 2 doctors. Exception, what is the exception? See, in case of congenital fetal malformation diagnosed by the medical board, you can see the gestational age limit for MTP nowadays is not applicable. Right? Now, listen to me very carefully. Coming here to the abortion, another topic, that is abortion. In abortion, you will see you have different types of abortion. One is the spontaneous, the recurrent spontaneous, induced abortion, threatened abortion. We will be discussing everything and every question point, important points simultaneously one by one. Chalo, come here. In spontaneous abortion, you will see it occurs in less than 20 weeks of gestation, right? So most common cause of abortion in first trimester generally is idiopathic, you already know. Apart from that, if they give you recurrent abortion history, then there can also be a case of APLA, antiphospholipid antibody syndrome. You guys know that. Now, then chromosomal anomalies. First trimester abortion generally very common, right? Due to chromosomal anomalies, trisomy, monosomy of X or trisomy of other chromosomes, right? Now, generally single episode abortion associated first trimester, single episode abortion associated with chromosomal anomalies. Now, if they give you recurrent abortion history, now I will tell you the approach to solve questions. Listen to me very carefully. What are the approaches? Two approaches I am going to tell you. First approach is, if they give you in the history that single episode abortion first trimester, you can easily suspect for chromosomal anomalies very easily. But if they give you recurrent abortion ka history, right? And when do you call it recurrent abortion? When there are 3 or more consecutive abortions, right? And investigation, when do you start? It starts typically after 2 miscarriages. Recurrent abortion ka history, first trimester. Then what you can suspect? Tell me guys. You can suspect for APLA. Now, I will tell you, moving ahead. Come here. Induced abortion, you will see. Medical termination of pregnancy can be performed up to 24 weeks. We already know. Induced abortion we have discussed. Just come here. APLA. What we are going to discuss. So, key antibodies they have asked you. Very frequently asked, commonly asked topic. Many times they have asked you, what are the key antibodies in APLA syndrome? So, the key antibodies are lupus anticoagulant, most commonly, right? Anti-cardiolipin antibody and anti-beta-2 glycoprotein antibody. These 3 names of antibody they have asked. Only these 3 you have to remember. Don't go in much detail. Just the 3 antibodies associated with APLA syndrome are lupus anticoagulant. Repeat after me and remember here itself. Anti-cardiolipin antibody and anti-beta-2 glycoprotein antibody. Done. Covered. Now, come here to the management of APLA syndrome. Treatment, nothing, just heparin and aspirin commonly used to manage the thrombosis and prevent complications, particularly taking place in the pregnancy. Now, after APLA, what we are going to discuss, the uterine anomalies leading to abortion. There are some uterine anomalies also, malformation in the uterus that can lead to abortion. Very common one are the septate uterus and the bicornuate uterus. If the uterus shape is septate or uterus is bicornuate, they are also common uterine anomalies because the fetus will not have proper space to expand or increase in size. So there will be high risk of development of abortion, right? You need not remember, from the common sense you can correlate and answer. Now, causes of second trimester abortion. First trimester we have discussed. क्रोमोजोमल एनोमैली, सिंगल एपिसोड अगर हिस्ट्री मिलेगा, मल्टीपल एपिसोड का हिस्ट्री, मल्टीपल रिकरेंट एबॉर्शन का हिस्ट्री मिलता है, मोर देन 3 एबॉर्शंस, राइट, इन फर्स्ट ट्राइमेस्टर, सस्पेक्ट फॉर एप्ला. एप्ला they have asked you very specific question, 3 antibodies, anti-lupus, lupus anticoagulant, right, anti-cardiolipin and anti-beta-2 glycoprotein. This much they have asked you from APLA, nothing else. Characteristic history, recurrent abortion, first trimester, APLA. आ जाओ. अब आओ, coming to the next topic. Next topic that we are going to discuss is, see here, second trimester abortion में, you will see spontaneous abortion generally we have discussed here, and recurrent abortion we have discussed, right? Cervical insufficiency major cause, one of the major cause, characterized by painless incomplete cervical dilatation leading to recurrent second trimester losses, right? Now, diagnosis of cervical insufficiency, tell me recurrent second trimester abortion में what you will see guys? History you will take. So patient with a history of recurrent second trimester abortion, if they give you in the question, and in the ultrasound finding they give you cervical length less than 2.5 centimeter or equal to 2.5 centimeter, this indicates the short cervix, right? Now, internal os diameter more than equal to 2 centimeter, which is suggestive of cervical dilatation also, and cervical shape is generally U shape. These are the signs of cervical insufficiency. Do you guys need to remember everything? No, not all the 3 points. For your point of examination point of view, only one point you have to remember, that is cervical length less than equal to 2.5 centimeter, indicating cervical shortening. This is only enough at your level. They have asked you many times. This is more than enough. Just have a look here for the cervical sufficiency. Now, coming here to the management of cervical insufficiency. Recurrent second trimester abortion, what will you do here? Go for the surgical treatment. What is the surgical treatment? You have to what you have to go for? Cerclage surgery. It is performed to prevent premature cervical dilatation. Right now, optimal timing for cerclage. What do you do? When do you do? You prefer in the 12 to 14 weeks of gestation, and it may be done up to 24 weeks. The cervical cerclage operation. Now, come here to the types of cerclage. You have the McDonald cerclage and the Shirodkar cerclage. They've asked you the names, cerclage operations. Just remember the names. It will be more than enough, right? So McDonald cerclage you will see most commonly used technique involving a simple, right, pressing strung around the suture around the cervix. You just put the suture around the cervix. McDonald cerclage, very easy. Shirodkar cerclage, you just involves the placing suture higher up in the cervix, usually under general anesthesia. No need to read the definition part. They don't ask you. Just remember the names, more than enough. McDonald cerclage and Shirodkar cerclage. Done. Coming here to the post procedure. What do you do at the post procedure? Cerclage suture typically you remove after 37 weeks of gestation. Why? Because you will have to remove, since you want the female to deliver, so you will have to remove the sutures so that the female can deliver. So after 37 weeks you will just remove the sutures. Now come to the type of abortion. When the internal os is closed, right? If internal os is again closed, then types of abortion just have threatened abortion. Simply, what will be the symptoms here? Slight bleeding will be there, few drops, or also they will write in the question spotting, right? A height of the uterus you will see corresponds to the period of gestation. In threatened abortion, outcome, it can be reversible. From the it is a threatened abortion, there is a threat that the fetus may get aborted. Here, if properly managed, it can be reversed. But in case of missed abortion, what will be the symptom? The discharge will be brownish discharge. Height of the uterus will be less than the period of gestation. And here the pregnancy has stopped progressing in the missed abortion. That means the product of the conception are still retained in the uterus or the womb of the mother. That means the pregnancy has stopped progressing, the fetus has died, but the products of the conception are present, still retained in the uterus, right? That is missed abortion. Coming here to the complete abortion. Incomplete abortion, what will you see? Symptoms: initial bleeding followed by the passage of the products of the conception, right? Height of the uterus, again you will check, less than the period of gestation, you have seen. And outcome, what will be the outcome? Bleeding stops after the expulsion of the products of conception, generally, right? Moving ahead, guys, one more type we have, that is the when the internal os is open. If you see in the abortion type, the internal os has opened. So if internal os has opened, then you will tell it as, you can categorize into two parts. One is the inevitable abortion. That means height of the uterus, again it will be corresponding to the period of gestation, right? Bleeding will be present, but what will happen? No products of conception has passed out, but the abortion is inevitable. Now you cannot stop it, right? It is irreversible. So abortion is imminent in case of inevitable abortion. Once you find the cervical os is open, internal os is open, and it is corresponding, uterus is corresponding to the height of the gestation, period of the gestation, and there is no product of conception that has come out yet, but still there is chance it will definitely come out, and it cannot be reversed or stopped. So that is inevitable abortion. Come to the incomplete abortion. You will see here height of the uterus is less than the period of gestation, again incomplete abortion. And in history you will get that some products of conception have passed, but not all the products have passed. Some are remaining, some are passed. That is incomplete abortion. Definitely you can understand. Now Come here to the outcome. What will be the outcome here? The outcome here will be that the abortion is incomplete and further intervention can be required to expel the remaining tissue. So now come here. Best method of MTP based on period of gestation. Can you tell me, guys? So one more question they have asked you regarding the another topic, that is what is the best method of MTP based on the period of gestation. So just have a look. If the period of gestation is less than 7 weeks, go for medical abortion. You already know, right? If it is between 7 to 12 weeks, these are all previously asked topics what we are discussing. So please be attentive every question, and when you will go and start solving the PYQs and PYTs, you can look and check that every topic will be covered. Not a single topic is being missed. So please be attentive. Yes, कुछ फालतू topics we have omitted because those that have less significance we have omitted because we have to cover in a shorter period of time. This is a rapid revision kind of class, right? So final intensive revision, all the only high topics have been discussed. Please bear with us, be attentive. At the end you will realize most of the topics have been cleared conceptually, as well as you will remember here from the class itself. Yes, now come here. You will see from 7 to 12 weeks, suction evacuation, Carmen evacuation, you can see here. Now, just have a look. More than 12 weeks, images we have given. Coming to the important topic of ectopic pregnancy. In ectopic pregnancy, what do you see? Most common site, generally they have asked one more question. The most common site for ectopic pregnancy they have asked, that is the fallopian tube, right? Most common non-tubal site, pay attention, they have asked this also. Non-tubal site most common is ovary. Most common site for tubal rupture is isthmus, right? Most common site for ectopic pregnancy where the tubal rupture takes place is isthmus. Now, most common site for tubal abortion, pay attention, is ampulla. These are all high one-liners. They have asked you very frequently. Again repeating, please pay attention. Most common site, right, for the ectopic pregnancy is fallopian tube. Most common non-tubal site, that means outside the tube, is ovary, right? Third is most common site for tubal rupture is isthmus, and most common site for tubal abortion, tube mein hi ho gaya abortion, it is ampulla, right? How to remember? AA, tubal abortion, A for tubal abortion and A for ampulla. Site, one liner you will have to remember. Ectopic pregnancy ends earliest in isthmus. If it is in the isthmus, it will end earliest. Ectopic pregnancy ends last, latest, सबसे late तक कब रहेगा? When it is abdominal, right? Now, most dangerous site for ectopic pregnancy is intramural part, right, or the cornual pregnancy. It is most dangerous. Most common risk factor, pelvic inflammatory disease. For the ectopic pregnancy, most common risk factor is pelvic inflammatory disease. This is also one of the important one-liner question they have asked you. Highest risk factor for ectopic pregnancy is previous history of ectopic pregnancy followed by tubal surgery, right? Wherever there is previous history, highest risk factor, simple. They will give you in the question, previous history of ectopic, simply suspect another case of ectopic only, because whenever a female has previous history of ectopics, in the subsequent pregnancy also, the risk of developing ectopic pregnancy increases many folds. Come here. Come to the management of unruptured ectopic pregnancy. Management of unruptured pregnancy, ectopic pregnancy. Investigation of choice. What you are doing, you will do is the transvaginal ultrasound, right? Best diagnostic approach, what it will be? Transvaginal ultrasound combined with beta HCG levels. You just have to look for both of them. Now, gold standard diagnostic method for ectopic pregnancy, if they ask you, is the laparoscopy. Always. Medical management or the first line treatment for ectopic pregnancy will be methotrexate. Now, in surgical management, two different approaches. For the nulliparous women, you do linear salpingostomy. Remember, linear salpingostomy. Why? Because you have to preserve the fallopian tube for the nulliparous woman so that she can conceive or she can be pregnant another time, right? For multiparous woman, what you have to do? You can do salpingectomy. If they give you that multiparous woman, family planning is complete in the history, what will be your line of approach for ectopic pregnancy? Surgical management, it will be salpingectomy. Ectomy, pay attention. You can remove the affected tube because her family planning is complete and she is already multiparous, right? Now, coming here to the topic of pregnancy induced hypertension. Somebody is asking, anatomy PDF not provided after class. Waste your. No. They have provided the PDF in the group. We have uploaded it, and today also we will upload. Just a minute. We will upload just after the class. No problem. Don't worry if you are thinking that we are not uploading. It is not like that. We had mentioned in the to the team. Some people were unable to join the Telegram link. That is why they were unable to download. But we had already posted it. We will provide another link also. If you have problem, I will discuss it with the technical team. We have given the notes. Notes will be with you. Now, pregnancy-induced hypertension. What you are going to see? Before 20 weeks of pregnancy, you will see, right? If there is hypertension persisting, it is classified as chronic hypertension in pregnancy. You already know if the female or the mother has hypertensive history before 20 weeks of pregnancy, it is, right, chronic hypertension. But after 20 weeks of pregnancy, if the mother is developing hypertension, it will be called as PIH or pregnancy induced hypertension, right? Now, and it should resolve within 12 weeks of delivery. That means after the delivery of the fetus, 12 weeks prior to the after to the delivery of the fetus, the hypertension symptoms in mothers should subside or go back, right? Now, diagnosis of preeclampsia. One more question. Preeclampsia associated with PIH, right? So we will be discussing with the topic of preeclampsia. They have asked you a lot many times. In preeclampsia, what do you find? Proteinuria is positive, right? It is more than 300 milligram per 24 hours, right? Or now you can see if there is sign of end organ damage, right? Diagnosis will be preeclampsia. Proteinuria with signs of end organ damage, diagnosis always becomes preeclampsia. Now, if there is proteinuria negative, no signs of end organ damage, then simply your diagnosis will be gestational hypertension and nothing else. Try to pay attention. Only if they tell you there is proteinuria and signs of end organ damage, then only you can diagnose it as preeclampsia. Come here. Now, pathophysiology. What will happen in normal pregnancy? You want to see the pathophysiology. After 20 weeks, what is going to happen? So, normal trophoblastic invasion is there, right? In normal pregnancy, what has happened? The trophoblastic invasion and replacement of smooth muscle layer in spiral arterioles leading to vasodilation. They are the spiral arterioles, you already know, right? And in the smooth muscle layer, there is invasion of the trophoblastic tissue, right? In normal pregnancy, it is completely normal and this leads to vasodilation. But in PIH, what happens? There is persistence of the smooth muscle layer, due to which what happens? There is failure of the migration or proper migration of the trophoblastic tissue invasion, right? Now, what will happen if the trophoblastic tissue fails to migrate or invade properly due to the persistence of the smooth muscle layer? What will happen? This will lead to vasospasms, right? And due to persistent smooth muscle layer in the spiral arterioles, persistent vasospasm, it can lead to pregnancy induced hypertension. The pathophysiology, they don't ask you very frequently, but we have discussed for the conceptual purpose, right? Now we will be differentiating between mild and severe preeclampsia. They have asked you a question when it is called as mild preeclampsia, when it is called as severe preeclampsia. Just have a look. When the blood pressure is more than 140 by 90 but less than 160 by 110, right? It will be called as mild preeclampsia. Simple. Severe, when we will call it, when the blood pressure exceeds by more than 160 by 110. It is called as severe preeclampsia. Now, if there is no sign of end organ damage, mild preeclampsia you can call it. Signs of end organ damage is present, it is severe preeclampsia, right? Now, come here. So, that for the timing of delivery, you can look delivery at 37 weeks generally, and severe preeclampsia mein you can go for delivery at 34 weeks, vaginal delivery. But in that case, again I told you, if the fetus, the age is less than 34 weeks, you have to give corticosteroid for the fetal lung maturation, and then you have to plan for the termination of pregnancy. Now, coming to eclampsia. In eclampsia, what is going to happen? Severe preeclampsia, nothing, just in the symptoms of preeclampsia, if they give you history of convulsions and seizure, it gets the disease called as eclampsia. Nothing else. That means eclampsia, how will you identify? Nothing. Just preeclampsia accompanied with convulsion, history of convulsion or seizures is enough. Then you will call it eclampsia, right? Now, what is the cause of convulsion? Nothing. Cause of convulsion is the cerebral hypoxia that is caused due to vasospasm, right? And endothelial damage in the brain. Now, how will you manage eclampsia? In the initial step, first of all, you will have to do emergency management. Eclampsia is an emergency condition. All emergency conditions, you know the management protocol. If they ask you next best step, simple. First of all, airway management. ABCD criteria, you already know. You have studied in the surgery, right? Airway management will be the first step. Now, ensure the airway and administer oxygen as you need. Now, after that, for management of eclampsia, what will you do? You will go with the pre-chart regime. Very famous regime, pre-chart regime. Two named regimes we have discussed. One was the McAfee-Johnson regime, right? We discussed previously. Now we are discussing pre-chart regime. Pre-chart regime is taking place in the management of eclampsia. Now come here. Management of eclampsia, pre-chart regime, you see, you have the magnesium sulfate. So what will be the loading dose? They have asked you many times. It is 4 gram IV bolus. Then we have the 10 milligram, 10 gram IM or intramuscular you can give. Then maintenance dose, nothing, just give 5 milligram IM every 4 hours, right? And how you have to give? 5 milligram in alternate buttocks, each buttocks. 1, 1, 5, 5, 5, 5, alternate buttocks you have to give, right? Now, you have to monitor. See, look at here. Magnesium sulfate is a good drug, but the problem associated with it is there is risk of magnesium sulfate toxicity. So you have to rule out for the toxicity as well. Okay? So for ruling out toxicity, what you will have to do? You will have to go for therapy. You will have to look for the magnesium sulfate toxicity signs. So how do you monitor the magnesium sulfate toxicity signs? You will have to look at the deep tendon reflexes or the patellar reflex. Very commonly they give it, right? You will have to look at the respiratory rate and the urine output. Three important criteria that you have to look for the magnesium sulfate toxicity. So coming here, guys, what is the first sign of magnesium sulfate toxicity? This is the asked MCQ point. They have asked you many times. First sign of magnesium sulfate toxicity, that is loss of patellar reflex or deep tendon reflexes. Khatam. Or very suppressed deep tendon or patellar reflex. Now come here. Antidote for magnesium sulfate toxicity, they have asked you from the pharma part, integrating the pharma and gynae part, calcium gluconate. Now come here to the management of eclampsia. Nothing, just you will have to terminate the pregnancy. Vaginal delivery will be preferred. If the patient not delivered between 24 hours of the first seizure, proceed with C-section. Simple. Done. Now, you already know if you are giving pre-chart regime, you will have to continuously keep on monitoring for the toxicity. Signs of toxicity, I have told you. Three important signs. Repeat after me. Patellar reflexes, right? The respiratory rate, and you will have to look for the urine output of the patient. Most important among them is patellar reflex, because this is the first to get lost, right? In the first and earliest sign of magnesium sulfate toxicity development. Okay, guys. Now come back. Yes, patellar reflex is also, that is only knee jerk reflex, Dr. Sunil. Coming here to the HELP syndrome. In HELP syndrome, what will you find? HELP syndrome, the name itself characterizes or signifies the HELP syndrome. In HELP syndrome, you have H for hemolysis, EL is elevated liver enzymes, LP is low platelet count. Done. Now, you see hemolysis, it is the destruction of the red blood cells. AL is elevated liver count or elevated liver enzymes, right? Indicating liver damage, right? Low platelet count, you already know. Thrombocytopenia, other name for it. Now, drug of choice for hypertension in pregnancy, they have asked you a lot many times. Even last to last year, they had asked you a question. They had given you one question that the person is having pregnancy-induced hypertension (PIH) and she has asthma as well. So, what will be your treatment? And they have given you multiple options. So we will be discussing all those things also right now. Don't worry. How to approach that kind of questions. Chalo, aa jao. Drug of choice for hypertension in pregnancy. Look here. Pregnancy-induced hypertension and preeclampsia. You already know labetalol is a drug of choice. But previously asked question, I'm telling you, pay attention. Last time they asked you, the female has PIH along with asthma. Will you give labetalol? The answer will be no. Why? Because it is a beta blocker. You already know what can beta blocker do, right? In the bronchus, it can cause bronchoconstriction. Am I correct? Bronchoconstriction, that means the asthma will precipitate. Since the lady had two things. What? The lady had a pregnancy-induced hypertension as well as asthma. So you cannot give labetalol. You will give alternative drugs. So just have a look. You have many alternative drugs. Methyl dopa as an option, hydralazine as an option, right? Looking at the options, you will choose your best answer. Okay guys, now just have a look. Chronic hypertension in pregnancy, again the drug of choice here is labetalol. Now have a look here. Methyl dopa is also an option. We have discussed. Hypertensive crisis in pregnancy, you know, again labetalol will be the drug of choice. Hydralazine is also effective but less preferred. In what cases you have to give? I have told you, अगर asthmatic का history है, then avoid beta blocker, go for the other drug given according to the option. If they give you hydralazine, you can go for it. If they give you methyl dopa, you can also go for that, depending on the question and the options. Be smart in approaching the question. Now coming here, preventing and treating convulsions in pregnant hypertensive females. What will you do? We have discussed. Convulsion है, that means जैसे ही PIH accompanied with convulsions, right, proteinuria, other signs of end organ damage, it will be eclampsia. Eclampsia आया Pritchard regime. बिना सोचे समझे Pritchard regime we have discussed. Magnesium sulfate you have to administer. कहानी खत्म. The story is over. Right? Now, you can come here. Other is safest antihypertensive drug in pregnancy, methyl dopa, very safe, right? Come here. Coming here to the gestational diabetes, another disease associated with pregnancy is gestational diabetes. So, peak insulin resistance, when does it happen? In the pregnancy, it generally, the peak insulin resistance happens between 24 to 28 weeks of pregnancy. And why does it happen? It happens because of increased levels of human placental lactogen. Remember the important points. Due to the increased levels of HPL, I will highlight the important points so that when I hand you over the notes, you can just recall the important points, and that will be more than enough for you guys. So, occurs between 24 to 28 weeks of pregnancy, and increased levels of human placental lactogen is there, right? And insulinase enzyme. These causes increased insulin resistance in the pregnant female, right? Now, risk of congenital malformation, and what is the duration? It is 24 to 28 weeks of pregnancy. Now, risk of congenital malformation, what will be the congenital malformation generally? Generally, diabetes mellitus does not increase the risk of congenital malformation, right? Very good. And what happens? It will generally resolve after the baby has been delivered, just like the condition of pregnancy induced hypertension. Just after the delivery of the baby, the condition after 12 weeks, the pregnancy induced hypertension used to resolve. Similarly, here also gestational diabetes mellitus, it will resolve after the delivery of the baby. Once the mother delivers the baby, after some time the symptoms will go. Now, coming here to the overt diabetes. What is overt diabetes? Overt diabetes is nothing when the mother, before getting pregnant, she was suffering from diabetes mellitus. That means pre-existing diabetes or diabetes existing before the occurrence of pregnancy in the female. That is overt diabetes mellitus. Have a look here. So, definition: when diabetic woman conceives leading to overt diabetes during pregnancy, we have discussed. Risk, again in the overt diabetes mellitus, there will be risk of congenital malformation, right? ये ध्यान रखना. Why? Because of poorly controlled blood glucose level early during pregnancy. Try to understand the two different points. The different point is कि overt diabetes mellitus में there is risk of congenital malformation to the fetus. लेकिन gestational induced diabetes में less risk, very less risk of development of congenital malformation. Right? Now, come here to the parameters for the gestational diabetes mellitus and overt diabetes mellitus. Simple parameter, you know, diabetes in pregnancy group of Dipsey criteria we use here, and overt diabetes mein very simple, you already know. Medicine you have studied, pharma and patho you have studied. Whenever fasting blood glucose more than 126 milligram percent, diabetes or overt diabetes normal in every person. Now, fasting requirement, no fasting is needed in GDM. Overt diabetes mein fasting is required apart from the testing. So here, glucose challenge test you do, right? Very frequently done in gestational diabetes mellitus. What do? You give 75 grams of glucose. This is asked question, so I am paying attention. So be very much attentive for this test. 75 gram of glucose in glucose challenge test they give you, right? And they check your blood glucose after 2 hours, right? If the blood sugar level is still above 140 milligram percentage, then it will be categorized as gestational diabetes mellitus. Okay guys, now having here to the overt diabetes mellitus, you already know blood sugar level after giving glucose, 75 gram glucose, it will be after 2 hours, it will be more than 200 milligram percent, right? And HbA1c values, they have asked if HbA1c more than 6.5, right, it is over diabetes mellitus. You already know that. Now coming here to the best investigation for fetal malformation, nothing, it is TIFA. Very easy, targeted imaging for fetal anomalies, right? Now, and here also same as GDM, and we have already discussed risk of fetal malformation, congenital malformation, more in over diabetes mellitus and less in gestational diabetes mellitus. Come here to the next topic and the next question. You can see here they have asked you about the timing of TIFA, right? Very important timing. When do you screen for the congenital malformation in diabetic patients, right? For screening 18 to 20 weeks, 18 to 20 weeks. TIFA scan, okay, done between 18 to 20 weeks or level 2 USG. Now coming to the congenital malformations. What are the congenital malformations in babies of diabetic mothers? They have asked. We have already discussed. So how will you just look out and screen for the malformation risk? Just have a look at the HbA1c level. Risk factor. How will you rule out that whether this pregnant female is at risk of developing congenital malformation or not? Look for the levels of HbA1c, right? It is the best investigation, asked question, best investigation for predicting malformation. TIFA scan, you know, why the USG done at 18 to 20 weeks, you can look for the congenital anomaly. Very good. But best if they ask you HbA1c. Why? Because HbA1c will be rising from the very beginning, right? It gives the HbA1c is a marker that indicates up to 3 months for the, it gives the history of past 3 months, whether the blood glucose control was good or not, right? So if you look for glycated hemoglobin, you can very easily determine if it is more than 6.5, it is in the range of 7.5, 8.5 or something like that. You can easily determine that yes, this female has over diabetes mellitus from the very beginning and she is at predisposed risk of developing congenital malformation. Am I clear, guys? I think I am clear. I hope that. Now just have a look. So most common congenital malformation, what will be there? It will be the ventricular septal defect in GDM cases, right? In over diabetes or diabetic mothers, most common congenital malformation is ventricular septal defect, and neural tube defects are also there but are lower in frequency. So if they ask you the best answer, they ask you that what is the most common congenital malformation, go for ventricular septal defect. If it is not in the option, second best answer will be neural tube defect. Now, most affected system, again they ask you. I told you VSD involving ventricular septal defect involving the cardiovascular system. So one cardiovascular system, most affected system, these are all MCQ points that have been asked. That is why I am discussing. Please be attentive. Now, if the CNS is involved, then again, you can see here, it is again the second most involved system. Coming here to the most specific congenital malformation. Most specific, if they ask you, it is the caudal regression syndrome or sacral agenesis of the sacrum vertebra. Most common heart disease in babies of diabetic mother, if they ask you, what is it? It is ventricular septal defect. Acha. Now, if they ask you most specific heart disease in babies of diabetic mother, what it should be? It should be most specific heart disease in the babies. Listen to me very carefully. In the babies of diabetic mother, it should be transposition of the great arteries. It is most specific, not most common. Most common, if they ask you, to be ventricular septal defect. Remember, right? Second most common, neural tube defect. Most specific for GDM deformities, they ask you. Most specific is GDM say transposition of great arteries. We have discussed, I hope, all the MCQ points. Now, management of diabetes in pregnancy. So, very easy. If there is diabetes, you will have to do fasting, blood sugar control, and lifestyle management or lifestyle changes, right? Am I clear, guys? So, lifestyle changes ke liye, what will you do? You will take proper diet, you will do exercise, right? And lifestyle changes for 2 weeks. Then, target to achieve in 2 weeks. What you have to achieve? You have to low down the blood sugar or level, that is fasting blood sugar level, you will have to bring it down. 1 hour postprandial blood sugar level, you will have to bring it down, and 2 hour postprandial level you will have to bring down. So have a look. Fasting, you have the more less than 95. 1 hour postprandial is less than 140. 2 hour postprandial is less than equal to again 120. So, and you know diabetes है तो क्या दोगे treatment में? Insulin you will have to give, right? Now, if they give you oral drug of choice in pregnancy, again insulin is the preferred diabetes drug of choice, right? In pregnancy, very easily you can look at here. Just have a look. Condition. you can look here what you have here. GDM control on diet, timing of delivery more than 39 weeks up to 40 weeks plus 6 days. GDM control on insulin up to 39 weeks more than or 39 weeks plus 6 days. Timing of delivery. Over diabetes में 37 weeks तक you can extend or up to 37 weeks plus 6 days. Beyond that, you will have to go for delivery. Now, the fetal effects and complications in diabetic pregnancies. Just have a look. Elevated fetal blood sugar, what will it lead to? It will stimulate the fetal pancreas, am I correct? To secrete more and more insulin. So excessive amount of insulin will be secreted. Why? Because the mother has diabetes, the blood sugar level in the mother is very high, very high. What it will look? It will look, tell me. The blood sugar level is very high. So what will happen? Tell me guys. If it is high, the high glucose will be transmitted to the placenta, via placenta to the fetus as well. So fetal glucose level will also be very high. What will the fetus do? It will start secreting insulin. If it secretes insulin, because the fetal pancreas will be hyperreactive to the increased blood sugar level. So insulin, and now insulin, you know that insulin and thyroxine both act as growth hormones in the fetus. So if more insulin is produced by the fetal pancreas, what will happen? It will basically lead to macrosomia, excessive fetal growth. Now you understand the reason why infants of diabetic mothers are generally large babies or macrosomia. Now, you will also find due to increased macrosomia, and there will be increased fat deposition, particularly around the shoulder regions, and increased risk of shoulder dystocia is also associated at the time of delivery. Now, complication of shoulder dystocia, you know, one of the complications is PPH. So now, management of shoulder dystocia, they have asked you questions regarding named questions regarding shoulder dystocia. Important question we are going to discuss very carefully. Sunna dhyan se. Now, in management of shoulder dystocia, what is going to happen? First maneuver, what do? You do the McRoberts maneuver, right? In this, you just flex and abduct the mother's leg over her abdomen to widen the pelvic angle and facilitate delivery. No need to get into the details. Even if just remember the named maneuvers, very easy, because they have asked you for your FMG exams, named maneuvers are more than enough, right? So first maneuver will be your McRoberts maneuver for management of shoulder dystocia. Here you are flexing the female, you can see the flexing the female leg and abduct the mother's leg over her abdomen. Why you are doing this? Because you have to widen the pelvic angle and facilitate delivery of the child. Coming here, have a look. Again, the second maneuver that you are going to do is Wood's corkscrew maneuver. In this is also an asked question. So these are all asked questions for your FMG exam point of view. These are the management of shoulder dystocia. So in the Wood's corkscrew maneuver, what you are going to do? You are just rotating the fetal shoulder to aid in the delivery. Just see, have a look. In this image, they are rotating the fetal shoulder from this side to this side ultimately, and then you aid the delivery of the shoulder, right? Last maneuver is the Zavanelli maneuver. In this, what happens if you see that you are unable to deliver? In Zavanelli maneuver, this is also an asked question, very important asked question, PYQ. High ekdam, I am telling you, this is ekdam for sure 1 marks question will be covered from this topic. Pakka aayega. Be attentive. Zavanelli maneuver, do nothing. Zava, Z for Zava, remember from the trick, Z for Zava. जिधर से आया, you are just going like in the Z shape. जिधर से आया उधर घुसा देना है वापस. Remember from this trick, very easy simple trick. Zava, Z, जिधर से आया, just insert the fetus. I mean to say gently push the fetal head back into the uterus, and then once you again push the fetus into the uterus, then you can go for emergency C-section. Bas, Zavanelli maneuver, I hope now you can understand. So 3 maneuvers, recall after me, repeat after me guys, because this is very important. First maneuver for shoulder dystocia is McRoberts maneuver, right? Here they will flex the mother's feet over the abdomen and take out the fetus, right? Why is it is done? It is done to widen the pelvic angle so that the delivery can be facilitated. Second is shoulder dystocia. Second maneuver is Wood corkscrew. You know how to remove the corkscrew. You know where is the cork present? Cork is present in the wine bottles, and corkscrew, you just turn it. Very similarly, you just have to rotate the shoulder. Why you have to rotate the shoulder? So that you can easily deliver the baby. So second maneuver is Wood's corkscrew maneuver. Last maneuver, what you do is when you are unable to deliver, you just जिधर से आया Zavanelli Z, जिधर से आया उधर डाल दो, जस्ट इंसर्ट द हेड back into the uterus and go for emergency C-section. Very important, asked question, asked PYQ. I'm repeating again and again. चलो अब आ जाओ oral hypoglycemic agents given in pregnancy. We have discussed one more important question. We discussed the drug of choice generally will remain the insulin itself, but oral hypoglycemic agent metformin and glyburide. Most important, metformin. Very important, if they ask you, generally ask metformin only. ठीक है, they are the only OHAs approved in pregnancies. Now fetal and neonatal complication, because from the pharma side they can ask you like this, only oral anti-hypoglycemic agents, right, or oral hypoglycemic agents approved in pregnancy. So metformin and this, metformin is the first preferred asked question, asked answer, khatam. Now fetal and neonatal complications in diabetic mother, you know the fetal complication we have discussed. Hyperglycemia, because the mother is hyperglycemic, fetal will also be hyperglycemic. Fetal stage में जैसे ही delivery हो गया, once the baby comes out, what will happen? The baby's pancreas was actually accustomed to secrete large amount of insulin. Why? Mother had diabetes, fetal had diabetes, right? Mother had diabetes. From the mother, high amount of glucose was crossing the placenta and coming into the baby. So the fetal pancreas was accustomed for secreting large amount of insulin in order to control the hyperglycemia due to the mother, right? Once the baby comes out into the nature, now there is no hyperglycemia to the baby, right? What will happen? Its insulin and its pancreas are accustomed to secrete large amount of insulin. What will happen if they secrete large amount of insulin? Then baby will suffer from neonatal hypoglycemia. Very important complication, remember. I hope now you can understand the concept. You don't have to remember. जब तक मां के अंदर था बच्चा, until the baby was present in the mother's womb, it was secreting large amount of insulin to combat the maternal hyperglycemia, right? जब तक गर्भ में था, until it was present in the mother's womb. When it came in the outside world, जब बाहर आ गया तो क्या होगा? जैसे ही बाहर आया, आदत तो इसे थी, फीटस को 9 महीने तक अंदर था, तो it was habituated for secreting large amount of insulin. बाहर आया as a neonate, again the pancreas and the beta cells will stimulate and secrete large amount of insulin, and due to this, what will happen? There will be neonatal hypoglycemia to the neonate. धीरे धीरे the child will adjust, but initial stages में he will suffer from neonatal hypoglycemia. Very important complication, remember. Very important question point I have highlighted. NEET PG में they can ask you, right? FMG में अभी तक जनरली नहीं पूछे हैं, but yes they can ask you, making it a pediatric point, that maternal hypoglycemia का important risk factor क्या है? तो one of the risk factor is diabetes mellitus, GDM, or overt diabetes mellitus to the mother, right? Now I think there is some internet issue. The image we have put it very clear, but maybe it should resolve. We will talk to the technical team. It will be done. Some people are telling the image is not clear. I hope. चलो अब आ जाओ. Hypomagnesemia is there. Hypokalemia again. Syndrome, what will happen? There is a syndrome that includes jaundice and polycythemia in the neonatal, right? Respiratory distress syndrome can also be there in the neonates. Most important VVIP point, only one that is important, that is hypoglycemia. Very important, because high risk, high probability asking question. Either they will give you a question of pediatrics or gynae. They can ask in any form. Now coming to the types of pelvis, there are various types of pelvis. You will have to look, right? The diameters also, we have the transverse diameter. You know, this is the transverse diameter of the pelvis. This is the antero-posterior diameter, right? Sacrum and the pubic symphysis ke between, right? Oblique diameters you can see here. Now, just have a look. Antero-posterior diameter at the pelvic and pelvic inlet. At the pelvic inlet, the antero-posterior diameter is 11 centimeter, right? At the pelvic inlet, the transverse diameter is 13 centimeter, right? And oblique diameter is 12 centimeter. This you will have to remember. Very simple. Remember like this. I will make you remember very easily. Just be patient and bear with me. At pelvic inlet, how will you measure the diameter? See, at pelvic inlet, the anterior posterior diameter is 11. Now, just rotate it like a clock. At AP diameter, pelvic inlet पे 11 था. Oblique में क्या हो गया? 12. राइट, एंड अल्टीमेटली इट बिकेम ट्रांसवर्स। ट्रांसवर्स हुआ तो क्या बन जाएगा, इट विल बिकम 13, 11 12 13। यू कैन सी इट वेरी इजिली, AP diameter, then oblique, and then transverse, AOT, done, 11 12 13, very easily, you will not forget now onwards. Coming to the pelvic cavity, in the pelvic cavity what will you see, you see here the anterior posterior diameter again constant in the cavity, all the diameter 12 12 12, no need to remember. Pelvic outlet, you see just reverse the AP and the transverse ones, bas khatam, AP will become 13, transverse will become 11. Now guys, we will just move ahead. Now there are two specific types of pelvises that they have asked you. Naegeli's pelvis, right? One ala of the sacral bone is absent and delivery mode here required is C-section, right? Now we will have to look at the stages of the labor and the question. They have asked you questions from the stages of labor. So we will be looking here at the stages of the labor. Be attentive. Stage 1, stage 2, stage 3 and 4. We will be discussing all the aspects and all the question point we will be covering in this table only. Be very attentive. In the stage 1, what do you see? See, in the starting point, there is true labor pain begins. That is the starting point for stage 1, right? When do you call ending of the stage 1 of the labor? When when there is full dilatation of the cervix, right? Now, see, stage 1 of the labor has two phases. One is the latent phase, other is the active phase. When do you call latent phase? In latent phase, true labor pain begins, beginning point. Ending point for latent phase is when the cervical dilatation reaches 4 centimeter. Khatam. Just have a look. Latent phase, starting point is beginning of the labor pain, true labor pain, and ending point is when the cervical dilatation reaches 4 centimeter. Stage 1 latent phase covered. Now, in nulliparous women, they have asked you about the duration. It takes 12 hours for reaching of the generally for the latent phase. In multiparous women, it takes 8 hours. Done. Coming to the active phase of labor. In active phase, what is going to happen? You have when the cervical dilatation moves up to the latent phase, it was 4 centimeter, beyond 4 centimeter or 5 centimeter beyond, or you can write in some textbook they mention 4 to 6 centimeter. Some for the simplification they write more than 5 centimeter dilatation. No need to get into controversies. Very simple. Latent phase 5 4 तक था तो 4 के beyond whatever dilatation, be it 5 be it 6, simple, don't get into controversies, apply your brain and just start solving. Dilatation, that will be beginning of the active phase of the labor, right? When what will be the ending point of the active phase of labor? It will be dilatation up to the 10 centimeter, right? Now just have a look. In nulliparous, what will be the duration, and multiparous, what will be the duration? In nulliparous, you can see generally active phase of the labor, they have asked you about the speed, not very commonly, but 1.2 centimeter per hour and 1.5 centimeter per hour. Multiparous, generally they have not asked you about the duration, so no need to worry for the FMG exams. What you have to remember, very simple, latent phase and active phase. Latent phase up to 4 centimeter, active phase where up to 10 centimeter. Khatam, from 5 to 10. Done. Coming to the stage 2 of the labor. Stage 2, starting point will be always 10 centimeter, up to 10 centimeter. The dilatation had taken place in the active phase itself. In the stage 2, what is going to happen? 10 centimeter dilatation of cervix will be there. Now, you see, ending point of stage 2 is delivery of the baby. From 10 centimeter dilatation to delivery of the baby is your done stage 2 of the labor. In nulliparous women, it is generally 1 hour. Multiparous, it is adha ghanta, half of that, 30 minutes. Stage 3. Stage 3 of the labor, what you are going to do? You are going to see after the delivery of the baby, you have to wait for the delivery of the placenta. Stage 3 में वही है, बस starts after the delivery of the baby and ends after the delivery of placenta. Stage 3 done. Time बहुत कम, placenta is a small part, so delivery time only 15 minutes in the nulliparous and 5 minutes in the multiparous. Done. Stage 4, nothing, it is nothing, just an observation period of 1 hour post delivery, both in nulliparous multiparous. I hope now you can recall and remember all the 4 stages. What was your first stage of labor? Discuss after me guys. मेरे साथ साथ यहीं पर याद कर लो. Beginning point था true labor pain का, right, in the first stage, and ending when the cervical dilatation reaches 4 centimeter. खत्म stage 1 का, latent phase over. Active phase of stage 1 कब होगा? From 5 centimeter to 10 centimeter, that is active phase of stage 1 khatam of cervical dilatation. Coming to stage 2, what you will see now in the latent phase and active phase you discuss. Stage 2 mein, that is from 10 centimeter cervical dilatation to delivery of the fetus. Stage 2 over. In stage 3, from after the fetal delivery to delivery of the placenta. Placenta की delivery होने तक, that means after the delivery of the placenta, is stage 3. Stage 4 कुछ भी नहीं है. It is just an observation period of 1 hour after delivery, both in multiparous and nulliparous women. खत्म. I hope we have remembered. Now, when do you call it a true labor pain? True labor pain when there is adequate uterine contractions, right? And when do you call it as adequate uterine contraction? Adequate uterine contraction कब बोलोगे? जब contraction 10 मिनट में 3 contractions होगा and each contraction should last for at least 45 seconds, right? Now, coming here to the topic of tachysystole, if there is more than equal to 5 contractions per 10 minutes, which can cause fetal distress, right? Tachysystole. Now, head movements during normal vaginal delivery. So, normal vaginal delivery ke dauran, what can be the head movement? So, extension. The head movement occurring during normal vaginal delivery is extension. So, extension, right? Now, head movement, that will be these are the asked one-liners. We will be discussing all these one-liners. Head movement in breech presentation or face presentation, the head movement will be flexion, right? So, in normal vaginal delivery, the head movement observed is extension, right? And in breech presentation, the head movement observed is flexion. Now, most common lie, one more one-liner they have asked is longitudinal lie, most common lie. Most common presentation is cephalic presentation. And most common presenting part is vertex, right? Most common position during delivery is left occipito-transverse. Better answer as compared to left occipito-anterior. Pay attention. All these one-liners we are going to discuss. One-liners asked very frequently. मेरे साथ साथ याद कर लो guys. Just be attentive. So, repeat after me. साथ साथ यहीं पर. Right? Most common head movement. Normal vaginal delivery में extension. Right? Now, head movement during the face presentation or breech presentation, it is the flexion. Right? Now, most common lie if they ask you, it is the longitudinal lie. Right? Most common presentation if they ask you is the cephalic presentation. Now, most common presenting part will always be vertex, and most common position during delivery is left occipito-transverse. Preferred answer as compared to left occipito-anterior. I hope you can understand. If they give you in the option only left occipito-anterior, then it will be the good answer. But if they give you both the options, then better answer will be left occipito-transverse. Now, most common fetal attitude is flexion. One more question they have asked you about the active management of third stage of labor. Very frequently asked question in the college days also. They ask you in the theory exams. They ask you very commonly active management of third stage of labor. Very frequently asked. So, in the active management of third stage of labor, first what do you give? You give injection oxytocin, right? You administer it within 1 minute of delivery to prevent postpartum hemorrhage or PPH. Now, drug of choice for uterine contraction is the oxytocin again, right? Remember one thing, that oxytocin is never given as IV bolus. Why? Because there is risk of severe hypotension, right? So you don't give oxytocin IV bolus mein. Come here. Delayed cord clamping. So important point, first, active management of third stage of labor. Pehla point, oxytocin injection. Characteristic for oxytocin we have discussed. Some other points that they ask you, drug of choice, uterine contraction, others. Now, second step what you do for active management of third stage of labor is delayed cord clamping, right? Third what do you do is placental delivery. And how? Using controlled cord traction. This is more than enough for you guys. These all points are only important for your examination point of view. Just 3 points. One, oxytocin, delayed cord clamping. Third is placental delivery via controlled cord traction. Khatam. Now, they have asked you from the pharma-gyne combination part one question regarding the methyl ergometrine, right? It is generally given as an alternative to oxytocin for uterine contraction post-delivery, right? Just remember, if they ask you alternative drug for oxytocin, for uterine contraction post delivery, it is methyl ergometrine. What is the contraindication? So methyl ergometrine generally given after delivery of the, not given after delivery of first twin. अगर भाई सिंपल सी बात है, if there are two babies, you cannot give methyl ergometrine after delivery of first baby, right? So it is contraindicated. Very simple, nothing, no need to remember, common sense. Yeah. Now organic heart disease is there, you cannot give methyl ergometrine, right? Preeclampsia cases also you cannot give methyl ergometrine. These are the contraindications. If preeclampsia is a contraindication, eclampsia naturally becomes the other contraindication. You know, preeclampsia and eclampsia are same thing, except eclampsia has history of convulsion and seizures. बाकी सारे फीचर्स सेम है. प्री एक्लैम्सिया में जैसे ही तुम्हें हिस्ट्री ऑफ कन्वर्जन और सीजर्स मिल जाएगा, एक्लैम्सिया बन जाता है. वेरी गुड. तो अगर प्री एक्लैम्सिया इज अ कॉन्ट्राइंडिकेशन फॉर मिथाइल ergometrine, एक्लैम्सिया ऑटोमेटिकली बिकम्स a contraindication for methyl ergometrine, right? Now coming here and look here at the indications of early cord clamping. One more question they have asked you, that what are the indications of early cord clamping? Early cord clamping कब? ऐसे तो delayed cord clamping we studied active management of third stage of labor. What did we study? 3 points: oxytocin injection, delayed cord clamping, right, and placental delivery via controlled cord traction. But they ask you, ठीक है, delayed cord clamping तो करते हैं, but what is the exception? Sometimes you have to do early cord clamping. And what are those cases जहां पे तुम्हें early cord clamping करना पड़ेगा, right? They have asked you. Now for those questions, very important ask PYQ. I am covering all the important ask questions, so be attentive. The question here is, see, birth asphyxia. If there is history of birth asphyxia, then you have to go for delayed cord clamp, early cord clamping, right? If there is need for neonatal resuscitation, सिंपल सी बात है, दिमाग से सोचो, बर्थ एस्फिक्सिया फीटस को, यू कैनॉट वेट फॉर डिलेड कॉर्ड क्लैंपिंग, जल्दी निकालो, अर्ली कॉर्ड क्लैंपिंग करो, सेव द फीटस, राइट? नियोनेटल रिसस्किटेशन का नीड है, इन दैट केस ऑल्सो फीटस इज नॉट रेस्पॉन्सिव, यू हैव टू सेव टाइम फॉर द फीटस, do early cord clamping, save it, no need to remember, apply your common sense, you will automatically reach to the answer, right? Now congenital heart disease in the baby, again RH negative pregnancy, you have to do early cord clamping, because you know, if there is mixture of the maternal and fetal blood, there can be risk, right? There can be risk to the life of the fetus, so you just do early cord clamping in RH negative pregnancy. Common sense, no need to remember. HIV positive mothers, you again know, you want to avoid the few mixing of the maternal and the fetal bloods, right? So you do early cord clamping early as possible. These are the indications for early cord clamping. ऐसे थर्ड स्टेज ऑफ लेबर में क्या करते हो? You do delayed cord clamping. Now come here. Characteristic of fetal heart rate. Fetal heart rate का characteristic देखते हैं हम लोग. आ जाओ. Here you will see if the fetal heart rate between 110 to 160 beats per minute, right? Now the variability and the acceleration. If less than 110 fetal heart rate, it is called as bradycardia. If more than 160, it is called as tachycardia, right? Fetal heart rate variation, if it is between 5 to 25 beats per minute, right, it is called as within normal range. Little variation of 5 to 25 beats per minute will be there in the fetal heart rate. You can see in the NST, you will find it very normal, right? Now if variability decreases or fixed sinusoidal pattern, then it can be problematic. Now fetal heart rate acceleration, whenever fetal heart rate movement occurs, fetal heart rate should increase, right? If fetus is moving, the fetal heart rate should increase by 15 beats per minute, right? Fetal heart rate acceleration will always be there, right? If there is fetal heart rate acceleration, that is a good indicator, that means the fetus is healthy. Chalo, aa jao. Just come here and look at the another questions. Normal fetal movements, number of normal fetal movements. I told you, if fetus will move, there will be increase in the heart rate, there will be acceleration by 15 beats per minute. Heart rate बढ़ेगा तो fetal heart rate acceleration दिखाएगा. That is a normal and positive good finding. Now suppose if there are 10 movements, and now you have to count the number of fetal movements. For counting number of movements, what you have to do, you will have to look what 10 movements within 2 hours of rest, or 10 movements within 12 hours of the activity. समझो, if mother is at rest, 10 movements are there within 2 hours of rest, then it is normal. Or 10 movements within 12 hours of activity, mother is doing activity, then 10 movements. Okay. Now if fetal movements are absent, first step क्या करोगे? अगर मान लो if there is no fetal movement, mother comes to you and tells that she cannot feel the fetal movement for a longer period of time, or you find that the fetal movement is absent, what will be your next best step? This can be the question. So first step will be modified biophysical scoring, right? And the second step will be non-stress test or NST. ठीक है, मॉडिफाइड बायोफिजिकल स्कोरिंग क्या है? कुछ भी नहीं है, एनएसटी और एमनियोटिक फ्लूइड इंडेक्स का कॉम्बिनेशन है। समझो बात को, एनएसटी इज अ प्रॉपर टेस्ट, एमनियोटिक फ्लूइड इंडेक्स तुम करते हो, राइट? स्कैनिंग के थ्रू तो यू चेक इट। नाउ इन दोनों के कॉम्बिनेशन को यू टेक आउट अ स्कोर दैट इज मॉडिफाइड बायोफिजिकल स्कोरिंग, एमबीएस, राइट? सो ये कब करोगे? फर्स्ट स्टेप क्या है? व्हेनेवर द मदर कम्स एंड कंप्लेन्स दैट देयर इज नो फीटल मूवमेंट, यू गो फॉर फर्स्ट step MBS, then the second step will be NST. MBS you find NST plus amniotic fluid index, right? NST used to assess fetal well-being, especially for detecting acute problems. Indicated at 32 weeks of pregnancy, right? For high risk patients, repeat twice a week. Done. For uncontrolled diabetes, repeat daily. Can you understand? NST में क्या करना है? Initiated. When do you initiate NST? When the pregnancy reaches 32 weeks of gestation. उसके बाद you start the NST, right? If the patient is at high risk patient, then you have to repeat NST twice a week. हफ्ते में 2 बार. In a week you have to do 2 times NST for any high risk patient. Now, if the diabetes is uncontrolled in patient, then what you can do? You can repeat the NST daily. Now, amniotic fluid index, what does it help in? It helps in assessing chronic issues of fetal well-being. Amniotic fluid index का role you have already known, right? It helps you in assessing in the fetal well-being, chronic issues regarding the fetal well-being. Now, just have a look here. We have here the types of deceleration. NST का monitoring they can give you and they can ask you early, late and how to identify. With this image you can identify very easily. I have put it, summarize it NST में. Just have a look. See, uterine contraction is there, mother maternal uterine contraction, and this is the fetal heart rate. जो टेढ़ा 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 करके रहेगा, that will be the fetal heart rate. Now you have to correlate. See, in late what will happen? See, in uniform shape, first we'll discuss the early type. The shape will be uniform, you can see here, but the lowest point of the fetal heart rate will generally correspond to the maternal contraction. You can see the peak here is corresponding to the lowest point. Early में, you can look, the peak and the lowest point are corresponding early में, right? In late what is going to happen? Uniform shape, gradual shape, but the lowest point just appears after the uterine contraction. Have a look here, the uterine contraction is here and the lowest point is appearing just after the uterine contraction. It is the late one. You can see just after the uterine contraction the lowest point is coming. Late phase. In the variable phase what is happening? Common phase, they vary in shape. Variable shape has no correlation, it is more common. Contraction अपनी जगह है, the peak and the dip will be at its own place. Variable phase. I hope we have discussed and cleared it with this image. Now, looking at the types of acceleration and deceleration, very frequently they have asked, right? So if there is early deceleration, what you are going to do? Clinical significance, normal physiological, no response is needed. Late deceleration, what you can do? Most ominous deceleration requires intervention. You will have to go for intervention if there is late deceleration. And variable deceleration is there. What you have to do? You just have to go. It may indicate cord issues. You have to monitor the fetus and monitor closely. Done. No, you don't need to go into much detail. This much they ask you. We have discussed the how to read NST. Even if they give a very tough paper, they will give you this much, right? Now, coming here, deep transverse arrest. When does the deep transverse arrest happen? It occurs at the level of ischial spine, right? Most commonly seen in android type of pelvis. Management options for the deep transverse arrest include C-section, vacuum delivery and manual rotation followed by forceps aided delivery, right? Now, they have asked you also question regarding the management of bro presentation. So for bro presentation, what do? You just go for C-section, preferred mode for the bro presentation. One liner, very. Now, the mento-vertical diameter 14 centimeter is the key measurement for determining the feasibility of vaginal delivery. Just remember, but among this most important MCQ point is simple, bro presentation, go for C-section. Deep transverse arrest management generally happens, deep transverse arrest happens with android pelvis and management is C-section. vacuum delivery, manual rotation followed by forceps. Question, important question. Once we discuss the management for shoulder dystocia, that was asked. Another important point that has been asked is breech delivery ke maneuvers. The maneuvers, what the maneuvers do you do in breech delivery, right? If the delivery part is buttock, right, then the maneuver done is pinard maneuver. Just remember the names, don't go into detail. That is more than enough for you guys for your examination point of view. Presenting part is shoulder. The maneuver, Lovset maneuver, discussed. Right after coming head of breech, the maneuvers will be, you can easily see the Burn Marshall and malar flexion and the Piper forceps method. Among them, the best one is Piper forceps method. Done after coming head of the breech. No need to go into very much detail. Just remember the names, revision class, and this is more than enough for your examination point of view. Nothing more you will have to remember. So after coming head of breech, Piper's forceps, best method, shoulder, Losset maneuver, and here in the buttocks you will go for the Pinard's maneuver. They've asked you a question about the Leopold maneuver. Just have a look. Leopold 1, Leopold 2, 3 and 4, right? Superior fundus you can see here. In the Leopold 1 maneuver, superior fundus is palpated to determine consistency, shape and mobility, right? Leopold 2, what you are doing, you are placing both the hands. They can give you the image based question and ask you both sides of the uterus you are palpating, right? And determining the direction of the fetal back, right? In Leopold 3, what you are doing, you are determining the fetal part at the inlet and its mobility. And Leopold 4, what you are doing, you are checking for the fetal attitude and degree of fetal extension into the pelvis. Nothing. Coming to the important topic, that is a postpartum hemorrhage, right? Now, in the postpartum hemorrhage, it is generally defined as more than 500 ml of blood loss following a vaginal delivery. You know, in vaginal delivery, if there is more than 500 ml blood loss, it is PPH. In cesarean section, if there is more than 1 liter of blood loss, then it is a postpartum hemorrhage. You know, primary PPH, first 24 hours, right? Now, common cause of PPH, they have asked you, very important, 4 T's. Very important from the trick, 4 T's, tone, trauma, tissue and thrombin. The 4 T's are the causes, common causes of PPH, right guys? You can notice from here. So just have a look here. Now, mechanical methods. Now we will just discussing the stages. Stage 0, 1, 2, 3, what you are going to do. Stage 0, PPH risk assessment. 0, alternate, right? Stage 1 में more than 500 ml, ongoing blood loss. Get help, IV access, you will have to restore. Review the cause of the bleeding, that is the tone, trauma, tissue and thrombin, 4 T's we have discussed. Stage 2, if there is more than 1 liter blood loss, what you will have to do? Just consider hospital transfer, take blood samples, viral markers, clotting factors, PT-INR, go for the test, blood group, prepare. Now, if more than 1500 blood loss has happened, then what you have to do? Get help, right? Then hemorrhage protocol you will have to activate and you will have to bring in blood and other for management. Now coming here to the mechanical methods. Mechanical methods, what you are going to do? You are going to do first the bimanual compression. In the image they have demonstrated. Second, intrauterine tamponade you will have to put. Surgical method they have asked you. For the PPH we have discussed bimanual compression. Manual mein. Second is intrauterine tamponade. Surgical method mein you go for the B-Lynch suture. Then you go for the Heyman suture, right? And Cho square sutures. Done. Then after applying suture, even after that bleeding is not controlled, then you will have to go for, even if it is not controlled, you will have to go for stepwise devascularization. So for stepwise devascularization, first of all, you will pick bilateral uterine artery, then bilateral utero-ovarian anastomosis, right? And then bilateral iliac artery. Devascularization will be done. We have discussed for the PPH. This is very important. They have asked you many times. Bilateral uterine artery, then utero-ovarian anastomosis, and then the internal iliac arteries. Come here for the twin pregnancies. For the twin pregnancy, you can see here, guys, what we have here is type of twins. We have the dizygotic twins and the monozygotic twins, right? In dizygotic twins, dichorionic, diamniotic, right? Monozygotic twins, you already know, if less than 72 hours, splitting happens, then what will happen? Dichorionic diamniotic twins will be formed in the case of monozygotic twins. So, right? If in case of 3 to 8 days or 4 to 8 days the splitting happens, then it will be monochorionic. The chorion will be same, mono, but the amnions will be different, right? Monochorionic diamniotic. If splitting happens after 8 to 12 days, what will happen? Monochorionic, monoamniotic, the chorion will be also be the same and amnion will also be the same. The fetus will be present in same amnion, right? Now, if more than 13 days, then there is risk of conjoined twins, same monochorion, monoamnion, but and the fetus will also be conjoined. Now, coming for the chorionicity. So best determined, it is antenatally best determined by USG done at 12 to 14 weeks, right? T sign, you already know in the USG for the chorionicity, you look for the T sign. T sign, it is seen in the monochorionic diamniotic. सीधी सी बात है. When there is same chorion, you can just have a look. The chorion is same, but the amnion is different. So sign will automatically become T sign. In the ultrasound, you can look here, right? Now, twin peak or lambda sign. If there is twin peak or lambda sign, that means twin peak sign or lambda sign, like this. Different, right? So what you will see? Dichorionic, diamniotic twins. Khatam. Management, these are all the radiological signs. They will give you USG images and ask, or directly they can ask you for the name of the sign. Ki T sign seen in, so you will just answer monochorion, one chorion, diamnion, T sign, lambda sign seen in when there is dichorion, diamniotic twins. Now, management of twin pregnancy, you already know. Twin pregnancy, dichorionic, diamniotic, just normally deliver 38 weeks, uncomplicated. No need to worry. Monochorionic, monoamniotic, 34 to 37 weeks in between, you can deliver very easily, right? Monochorionic, monoamniotic, 30 to 34 weeks they have written, but yes, generally after 34 weeks you deliver. Now, postpartum mental health. Very important. Psychiatry, from the psychiatry question they have integrated and asked you many times regarding the postpartum health. Just pay very common attention. Psychiatry gynae combination. Questions they have asked you. Postpartum blues. What are they? Simply they will give you the history that the very common self-limiting condition that a pregnant female came after delivering. She was having psychotic symptoms but depressive symptoms, but it was self-limiting and it was occurring in the first few days of the postpartum and the symptoms subsided. She did not need any medication. It will be postpartum blues. Now, if they give you after delivery the female went into depression, it is prolonged stage, right? Fatigue, and she is having mood swings requiring treatment, then it will be postpartum depression. Longer period of time, few days postpartum blues, longer period postpartum depression. Features: postpartum psychosis, very rare but it can happen and it will require immediate medical intervention. They will give you history after delivering the female started behaving psychotically. See, they will give you other psychotic symptoms like aggression, right, or delusions or anything like that. They will give you the psychotic symptoms, very common, and they will tell you that it is persisting for a longer period of time. So emergency management you will have to do. I'm talking to the technical team for the screen issue. Screen is not clear. Just please check for once. So this treatment, you do not need to discuss the entire table. Very easily, question we have discussed. Treatment, if they ask you for depression, the resolution is not very clear. Video resolution. Maybe shared network issue is there. So now, treatment, what will you do for postpartum blues? Nothing. Just reassure. If they ask you treatment, just reassure. Don't do anything. Postpartum depression, if there is depression, antidepressant you will have to give, right? And counseling and psychotherapy. If there is psychosis, what you will have to do? Antipsychotic medications, you already know, antidepressant, and if it is an emergency condition, patient is too aggressive or suicidal tendencies you can see, then you can admit the patient and keep her under observation as well. Done and discussed. Coming here to the questions of anencephaly. Yesterday when we were discussing anatomy, we had discussed with the image all the cases. We need not put a lot of stress here, only the gynecological part we will be covering here, right? Here you can see the maternal serum alpha protein screening test used for detection of anencephaly, right? Best biochemical marker, you know, acetylcholine esterase, most reliable marker for diagnosing anencephaly, right? Now, diagnosis, it is done by via most commonly by transvaginal sonography, TVS, Earliest detection for anencephaly is at 10 weeks and most accurate diagnosis is made at 14 weeks. All the important signs. Very important frog eye sign, radiology, gynae integration. Very commonly they have asked for anencephaly. The frog eye sign, you can look here, right? So what are the important points that you have to look? Just have up attention. Pehla, alpha fetoprotein, right? Then earliest detection is can be done at 10 weeks, right? Via transvaginal sonography, and most accurate diagnosis for anencephaly can be made at 14 weeks, right? Most accurate, and the sign that is appearing is frog eye sign. In the question, if they mention you the sign, you will just put the answer frog eye sign. Understood, guys? Now, preterm labor. In the preterm labor, what you are going to see, it is defined as labor occurring before 37 weeks of gestation. You already know, we have discussed before 37 weeks, it will be the preterm labor, right? Now here, the cervical length to detect the preterm labor, a cervical length of less than 2 centimeter is associated with an increased risk of preterm labor. Right? Now, if the cervical length is less than 2 centimeter, that is, it is more specific predictor for preterm labor, right? Now, for the management of preterm labor, what you are going to do? If preterm labor appearing between 34 and 37 weeks, कोई treatment की आवश्यकता नहीं है. The fetal lung maturity has taken place after 34 weeks. No other specific treatment. You can go for delivery, right? Corticosteroids, if needed, you can give. Not necessary, not mandatory. But preterm labor, if it occurs before 34 weeks of delivery, pay attention. Fetal lung maturity has not been achieved. You will have to give corticosteroids and other tocolytics, MGS4 for neuroprotection of preterm labor at less than 28 weeks. But this is not very important from your examination point of view. The topic that is most important for preterm labor management, less than 34 weeks, corticosteroid. Why is it given? It is given for fetal lung maturity. I have discussed it, so I am writing it also. Now, they will ask you about the tocolytics, pharma and gynae integration. They have also asked you tocolytics. Nifedipine, it is preferred tocolytic in most of the cases, right? Atosiban, it is oxytocin antagonist. Now, best choice in case of heart disease. Nifedipine, also the best choice for patient with diabetes. Now, the best test to detect lung maturity. Two tests they have asked you, right? First is phosphatidylglycerol in amniotic fluid, right? Most reliable test for assessing the lung maturity. If the phosphatidylglycerol is present in the amniotic fluid, that means the fetus has achieved lung maturity. Now, lecithin sphingomyelin ratio more than equal to 2. It can be the common test used for detecting the lung maturity. Come here, guys. Additional consideration in preterm labor. What you have to do? A cervical swab, it is mandatory in all cases of preterm labor. You already know. Now, Down syndrome screening and diagnostic test. One more important question we are going to discuss. Preterm labor we have discussed, right? Lung maturity test करने के लिए two tests we have. They have asked you one important question. We will discuss phosphatidylglycerol and lecithin sphingomyelin ratio. Two tests. If more than equal to 2, then yes, detect fetal lung maturity. Now coming here, Down syndrome screening. They have asked you one more question very frequently. First trimester में and second trimester में different tests. Dual marker or dual test, you know, PAP-A and beta HCG. PAP-A is less and beta HCG is high. Done. First trimester में, right? And ultrasound we will find that the nuchal translucency is there. Second trimester में what do you find is the triple test. You do the triple test for Down syndrome screening. HCG will be high, AFP will be low, and unconjugated E3 will be low. Khatam. Come here, soft tissue markers, you already know here, nuchal translucency we have discussed, it will be there. Nasal bone will be not be properly formed, right? Femur will be short, humerus will be short, choroidal plexus में cyst will be there, and nuchal skin fold thickness will be there. These are the signs and the soft tissue markers that you will be looking for USG diagnosis, right, of the Down syndrome screening. Very important, only dual markers and triple test. You know, triple test most commonly asked, HCG will be elevated, right? Then in second trimester, AFP decreased and unconjugated E3 decreased. Signs of pregnancy in first trimester, again asked question, important topic. you have to look for the signs of the pregnancy. Goodell sign appearing at 6 weeks. What is the earliest sign of pregnancy it is? And it is characterized by softening of the cervix. The cervix becomes soft, right? And you find at the 6th week, this is the Goodell sign, earliest sign. Again, another sign is the Chadwick sign, indicating pregnancy that appears at 8 weeks, right? There is bluish violet discoloration of the cervix due to venous congestion. Now, signs of pregnancy for the first trimester, again, Chadwick and Goodell sign very important. Why? Because Goodell's was the earliest sign to appear. Chadwick can be seen by the naked eyes, bluish discoloration of the cervix, right, due to venous congestion. Now, Oslander sign, it is also happening at 8 weeks. Pulsation of the uterine blood vessels during pelvic examination, you can feel it. Palmer sign, regular rhythmic uterine contraction felt on bimanual examination, you can look here. Hagar sign, compressibility and softening of the cervical isthmus. All the signs you don't need to remember. I know they can ask you, but most important signs I will tell you are three. One is the Goodell sign, another is the Chadwick sign. Goodell sign most commonly occurring and earliest occurring sign 6 week per. Chadwick sign occurring at 8 weeks. These two signs very important. Now, signs of pregnancy in second trimester. Quickening, the fetal movements that can be felt by the female, right? Now, in primary gravida, it is generally felt after 18 weeks, and in multigravida, it is felt after 16 weeks. Quickening, right? Fetal movements, right? Felt by the mother. In Hindi, you call it laat marna, bacha laat mar raha hai, right? That is quickening, second trimester. Now, signs of pregnancy in third trimester. Lightning, also called as welcome sign, it refers to the fetus head advancing in the pelvis, right? Primary gravida occurs after 38 weeks, right? And in multigravida, when does lightning happen? Lightning happens just before the onset of the labor. Labor आने के just पहले lightning होगा. Listen to me very carefully. Lightning welcome sign भी कहलाता है, right? Refers to the fetal head advancing in the pelvis. Lightning. Now, in primary gravida कब होगा? After 38 weeks. Multipara में या multigravida what will happen? Just before the onset of the labor, lightning will be happening. Lochia, again important question. Again important topic. See, we are discussing topic wise, everything topic wise, important asked questions topic wise. We are just covering all the PYTs, previously asked topics will be covered via these notes, and I think we will be completing everything. Now, come here for the lochia. Lochia, source of lochia. If they ask you in question, best answer will be uterus, cervix, and then vagina. Depending, flow, वही है flow का system भी है, uterus, cervix, and vagina. Best answer, uterus, then cervix, then vagina. Now, normal duration of lochia 24 to 38 days after delivery. You know that. Types of lochia, 3 types of lochia we have, right? Rubra, serosa, and alba. Simple. Endometrial tissue, leftover tissue. When it will come out, it will be rubra. Rubra will be containing blood and the other tissues, so it will be red in color, right? First 3 to 4 days you will see it. Lochia serosa, pink or yellowish because a little bit amount of blood and serous fluid, so pinkish to yellowish color, 5 to 10 days. Then the lochia alba, that is generally alba signifies white in color, coming between 10 to 38 days, right? Finished. Now come here to the menstruation. Menstruation say they have asked you questions, so we will be not be, since it is a revision class, we will not going into the detail of the graph, but we will be discussing all the high yield question points asked from the menstruation and the answers. Simple. You already know peak estrogen, what is happening, seen on the day 12 of the cycle. Day 12 of the cycle, nearly on the day 12 of the cycle, the estrogen peaks in amount. You can see here from the yellow line or the black line that I have drawn. I will draw from 3 different colors so that you will be able to understand. Now, just have a look. Peak LH generally happens 24 to 36 hours before ovulation. So ovulation, you all know, occurs on the 14th day. No need to remember, just listen to me very carefully, conceptually. Ovulation occurs on the 14th day, right? Now, so LH peak will appear 24 to 36 hours before ovulation. So LH peak will be at 13th day. Done. Just have a look, guys. 13th day, LH peak has happened. After that, progesterone Peak progesterone will take time to peak. Why? Progesterone was being made by corpus luteum, right? So corpus luteum, it will take time to peak. So it will be seen on the day 22 of the cycle. Now, ovulation, you know the process, primary oocyte to secondary oocyte converted, right? The mature Graafian follicle ruptures and gives the ovum and converts into the corpus luteum that we already know. Now, important timelines, I have already told you LH surge will happen 24 to 36 hours before the ovulation, right? LH peak and ovulation again 10 to 12 hours before the after LH peak. Ovulation and LH peak के बीच में difference 10 to 12 hours, right? Now estrogen peak, LH surge again 14 to 24 hours before the LH surge estrogen peak. This is not very important timeline, but from the question point of view, these points are very important. Peak LH, peak estrogen, especially for the LH surge, they have asked you many times. Peak LH, when does it happen? Right? Now, coming here to the corpus luteum. So in corpus luteum, you already know what happens in the corpus luteum. Corpus luteum is maintained by the luteinizing hormone LH, right? The lifespan of corpus luteum in a non-pregnant female, the female who has not conceived, regular menstrual cycle happening female, non-pregnant female, the life of corpus luteum is 12 to 14 days, right? It will survive only for 12 to 14 days. Now, in pregnant female, what is going to happen? It is generally corpus luteum, you know, will be maintained by HCG hormone or human chorionic gonadotrophin. We have already discussed, right? Now, human hormone preventing luteolysis or degeneration of the corpus luteum is again HCG that helps in maintaining the corpus luteum, right? Now, by the day 22 of the menstrual cycle, corpus luteum generally attains maximum size and activity. So, and it also produces maximum progesterone on normal day 22 of the cycle. Coming here to the test of ovulation, again question they have asked. One more important question point that we are going to cover is test for ovulation. Ovulation tests, what are the tests and how will determine ovulation taking place? So, mitral smirch, you know, mid-cycle pain felt and reported by the female, very important. They have asked you one-liner, right? Dysmenorrhea, painful menstruation, again is a sign of ovulation. Now, premenstrual syndrome, PMS, again symptoms that occur before menstruation, and progesterone withdrawal leads to vasospasm and production of PGF2 alpha that also causes pain. That is why these are the normal signs based on the history. You can guess for ovulation. Most important among them, question asked is mitral smirch. Mitral smirch is the mid-cycle pain typically felt at the time of ovulation reported by the females. Now, if there are anovulatory cycles or irregular cycles, what will happen? It will be painless, not associated with painful menstruation. Now, heavy bleeding will be there due to estrogen breakthrough bleeding, not progesterone withdrawal. Now, come here, test for the ovulation. In ovulation, what is going to happen? In ovulation test, hormonal test के through, how will you determine कि ovulation has happened? Pay attention very carefully. Now, progesterone, I told you, measure day 22 of the menstrual cycle. Elevated blood progesterone level will indicate ovulation. Why? The corpus luteum reaches maximum size after 22 days, right? On the 22nd day of the cycle. So on the 22nd day, it will secrete maximum amount of progesterone. Progesterone will be in its peak. So blood progesterone level, if you measure, you can indicate that yes, ovulation has taken place. First marker. Second marker is body basal temperature. Basal body temperature will rise whenever ovulation takes place. You already know. Now, then you have to do one more thing, that you have to study for the cervical mucus studies. Regarding doing the cervical mucus study, you can decide whether ovulation has taken place or not. Very simple सी बात है. If the cervical mucus becomes thick, scanty and viscous, right, and if it cannot be stressed, the cervical mucus, right, then that means progesterone has reached its peaks. That means the ovulation has taken place. Simple सी बात. Cervical mucus is normally profuse, watery and elastic, right? If it becomes thick, scanty and viscous, that means ovulation. This is also an indicator for ovulation. Simply finished and covered. No need to get into very much detail. You can see here. And also one phenomena is called farning. when you do the microscopy, the fern-like appearance will be present in the cervical mucus. When ovulation has not taken place, whenever ovulation has taken place, ferning will disappear after day 17 of the cycle. So this is also an indicator for ovulation. Now, now, what here we are going to do is premature menopause, that will be going to discuss, right? Categorized as class 3 infertility, you can see characterized by primary ovarian insufficiency. ठीक है, class 3 infertility that is characterized by primary ovarian insufficiency. Here you will see hormonal profile in primary ovarian insufficiency. They have asked you as a question form. So what will happen in primary ovarian insufficiency? The FSH will increase. Why FSH will increase? We have the hypothalamic pituitary axis. Hypothalamus will release GnRH. Then pituitary will release FSH and LH, right? FSH will keep on increasing. Why? Because on the ovaries more and more FSH will drop, and ovaries are insufficient, they are not working properly, so they will not give the negative feedback, will not come to the pituitary will keep on secreting more FSH and less amount of estrogen, because ovary cannot make estrogen. So what will happen in the primary ovarian insufficiency? More amount of FSH will be secreted from the pituitary, no estrogen or very less amount of estrogen from the ovary. Simple science, you can just have a look. FSH increased, estrogen decreased, and anti-Mullerian hormone also decreased, and inhibin B also decreased, right? Just have a look. Inhibin B decreased, estrogen decreased, and AMH decreased. This is the case that you will see in primary ovarian insufficiency. Now, ovarian reserve test. When you are doing ovarian reserve test, what will you see? It is performed on dates 2 to 3 of the menstrual cycle, right? And how will you check? You will just look for the inhibin B, that will be decreased, FSH will be increased, and antral follicular count will be decreased. Now, just have a look at the FSH levels and the AMH levels for testing the primary ovarian insufficiency. FSH levels, if more than equal to 40 to 45 international units, right, confirms the diagnosis of menopause. If AMH level less than equal to 1 nanogram per ml, it is indicative of primary ovarian insufficiency. AMH level more than 3 nanogram per ml is suggestive of PCOS. What you have to remember for primary ovarian insufficiency? I'll tell you, FSH will increase, estrogen decreased, anti-Mullerian hormone again decreased, very less, right? And inhibin B is also decreased. But these 4 features you need to remember. AMH level will be less than 1 nanogram per milliliter, and it is solved. Primary ovarian insufficiency test, it is done. Now, we are coming here to an important concept of types of abnormal uterine bleeding, right? Just have a moment and have a look. You have the menorrhagia, then you have the hypomenorrhea, you have the oligomenorrhea, polymenorrhea, and metrorrhagia. These 4 terms, 5 terms, very frequently asked. Abnormal uterine bleeding. So what is menorrhagia? Menorrhagia is excessive menstrual bleeding, right? More than 85 ml, or for menstruation happening for more than 7 days, right? Now, commonly seen in, where do you see it commonly? It is seen in the case of fibroids. Hypermenorrhea, you see it is a reduced menstrual bleeding, right? Hypomenorrhea, reduced menstrual bleeding. Bleeding amount will be less than 5 ml and for less than 2 days. Done. Associated with Asherman syndrome. Oligomenorrhea, you already know, long menstrual cycles. Oligo means menstruation is less. How it will be less? Because the cycles are prolonged, duration is prolonged, long menstrual cycles. And what will happen here? Fewer cycles per year, because in a year you have limited amount of months, 12 months and 365 days. If one cycle is beyond 35 days, or suppose of 40 days, number of cycles per year will automatically decrease. So oligomenorrhea, right? Polymenorrhea, what will happen? Short menstrual cycles, suppose the cycles become less than 20 days. What will happen? You have 365 days in a year. So number of cycles in 1 year will increase very much. That is polymenorrhea. Coming to metrorrhagia. irregular bleeding or bleeding between menstrual periods, right? Often seen in case of polyps. Now coming to the case of PCOD, very frequently asked, polycystic ovarian disease. You know here in PCOD what is happening. The female will come to you, right? She will complain of irregular menstrual cycle, right? And other symptoms they will give you. Along with that, diagnosis we have discussed. Revision class, only important MCQ points we will be discussing. So try to listen in PCOS. More important MCQ point, they will ask you about the Rotterdam criteria. What is Rotterdam criteria? There are three criteria, and out of the three, two criteria need to be present there. Then you call it PCOS, polycystic ovarian disease. The first one is delayed periods. The patient will come and tell, Doctor Saab, I have delayed periods, right? Oligomenorrhea or anovulation will be there. The period and cycles will be anovulatory. Why? I will be telling you the conceptual part. Just be patient. Now, hyperandrogenism, androgen will increase too much, and USG morphology, it will be presence of polycystic ovaries on the ultrasound. You can see here, like the string of pearls, you can find multiple polycystic ovaries in the ultrasound, and the ovarian stroma is thickened, right? So PCOS, why is it happening? Ovarian stroma gets thickened, right? Now due to that, there will be anovulatory cycles, multiple cysts will be formed, and each cyst will be less than 10 size, right? And more than 20 follicles if you find, then you can, or 12 to 20 follicles if you find, then you will call it PCOS, right? Now for the management, just have a look here, guys. Management, what you will do, if the female is young, unmarried, you do not need to ovulate her. Just tell her, first of all, do for lifestyle management, BMI control, diet and exercises. Done. For regularizing the menstrual cycle of the female, unmarried female both, you will give her COCPs, combined oral contraceptive pills, very common, right? Now, if the female comes to you and tells you, the doctor, I want to be pregnant. If she is married female, she is in the reproductive age group, she wants to reproduce, then what will you do? You will go for ovulation induction, right? For ovulation induction, what will you prefer? You will prefer first line drugs such as letrozole, right? Then clomiphene citrate, second line drug. The more commonly preferred drug is letrozole, you already know. And what is the risk with these drugs? Ovulation inducing drugs, the risk factor associated will be ovarian hyperstimulation syndrome, OHSS, right? Remember the risk. Now just have a look. In PCOS, what you do? You do symptomatic management. Also, one drug that you can give is metformin, very commonly prescribed in the PCOS for regarding the insulin insensitivity that is there. Now, coming here to the topic that is puberty. In puberty, what you are going to see, in puberty you will see normal age of the pubertal females. You know puberty, when it will begin around the 10.5 years, right? Menarche typically 2 years after the onset of puberty will happen, that is 12.5 years. Remember very easily, menarche, it will be happening after 12.5 years. Puberty, it will be beginning after 10.5 years, right? What is precocious puberty? If the female becomes reaches puberty before the age of 8 years, right? Precocious puberty. Now, most common cause is idiopathic generally. Investigation, what do? You do MRI. Treatment, continuous GnRH analogs you are giving, right? Now, there is a syndrome here, McCune-Albright syndrome. You can see the features here will be precocious puberty, cafeolate spot, right? And the bony lesions will be there. Now, delayed puberty, what you will see? The puberty if attained after more than 13 years. Precocious puberty earlier than 8 years, delayed puberty more than 13 years, right? Again, treatment here will be pulsatile GnRH therapy to stimulate the puberty, right? Tanner staging you do, right? Stage 1 and stage 2 for the underdeveloped sexual characteristics, and stage 4 and 5 indicate well developed sexual characteristics. Tanner staging, not very commonly asked. Now coming for the signs of the puberty. So for the signs of the puberty, you will see first sign of puberty is growth, height increase or the growth spurt, right? You might have studied in the pedia, they ask you, so this is pedia and gynae integration. First sign of puberty, again growth. Second, first visible specific sign in female, what is it? Tell me guys. The first visible specific sign in female is thelar, right? Development of the breast tissue. Then comes the pubar, development of the pubic hair, and then peak height velocity or the rapid growth phase, right? And at last comes the menarche, that is the onset of menstruation. Remember, first development of breast tissue, thelar, then comes the pubar, then height velocity, peak height growth velocity or the rapid growth phase, and then comes the menarche, that is the onset of menstruation. Earliest sign of puberty in males. What is the earliest sign of puberty in males? It is the testicular enlargement when the testicles enlarge, often first sign of puberty in the males. Coming to the diseases of such as endometriosis and adenomyosis. Endometriosis, what is it? It is commonly seen in the nulliparous women. You already know, right? Most common site regarding endometriosis is endometrioma or the chocolate cyst of ovary. You can see chocolate cyst in the ovary where it will be formed. What is endometriosis? It is nothing but the growth of endometrial tissue outside of the uterine cavity. Uterine cavity के बाहर कहीं भी endometrial tissue का growth is endometriosis. You can just look. Most common site is ovary. You already know. Second most common site for endometriosis is pouch of Douglas in the very simplified language. Now, most common symptom will be dysmenorrhea, right? And that dysmenorrhea will be of secondary dysmenorrhea. Investigation of choice, if they ask you for endometriosis, will be laparoscopy, right? And what will you find? You will find gunshot lesions, powder burnt appearance or burnt powder like appearance. Management, all hyperestrogenic conditions के लिए क्या करोगे? What will you do? Endometriosis is due to hyperestrogenic condition, you already know. So for management, what you will do? You will give GnRH agonist, progestins, letrozole, danazole, and gestrinone and mifepristone. Done. Come here to the adenomyosis. Adenomyosis generally seen in the multiparous woman, right? Here what will be happening? Most common symptom in adenomyosis will be menorrhagia and dysmenorrhea, right? Now, the uterine size here generally will become bulky, but it should not exceed the size of 12 to 14 weeks of pregnancy. And investigation of choice, if they ask you adenomyosis, it will be MRI, right? Now, management, what is it? The management for adenomyosis is simple hysterectomy. It is the first line definitive treatment. Second line treatment is Mirena, right? It is the intrauterine device, levonorgestrel releasing device, progesterone releasing device, right? Chalo. You can look here in the adenomyosis, they will show in the muscles, there is the growth in the myometrial tissue of the uterus, there is growth of the endometrial tissue, proliferation. Uterus becomes bulky, thick in adenomyosis. Management first line is definitive hysterectomy. Uterine fibroids or leiomyomas, very important. In the leiomyomas, they have asked you a lot of questions, right? It is the development of fibroid tissue in the myometrium of the uterus, right? Leiomyomas also called as, it is a benign lesion. Remember, they have asked you whether it is a benign or malignant lesion. So leiomyomas are generally benign lesions. Now, listen to me very carefully. FIGO classification related to leiomyoma they have asked. One is the most common type of fibroid they have asked you. It should be intramural, right? Submucosal and then subserosal type. Most common is the intramural leiomyomas. Then you can also have the submucosal, subserosal type. Pedunculated type is also there. FIGO classification is there, discussed for the leiomyomas. Most common symptom for leiomyomas, you know, it is menorrhagia, heavy menstrual bleeding, and other urinary symptoms are cervical fibroid, right? Anterior cervical fibroid will increase urinary frequency. Posterior cervical fibroid, if that is present on the posterior side, it will increase urinary retention, right? Now, fibroids associated with maximum symptoms or infertility will be submucosal fibroids. Now, in the leiomyomas or fibroids, they have asked you about the fibroid degeneration. So there are three types of degeneration. One is the hyaline degeneration, right? And red degeneration more commonly, and postmenopausal degenerations. Among them, most frequently, they have asked questions from the hyaline degeneration and the red degeneration. Hyaline degeneration, it is the most common type of degeneration. In the fibroid, they have asked you. Again, red degeneration, it happens most commonly in the pregnancy. These are both the MCQ points you will have to remember. Hyaline degeneration and red degeneration, most common degeneration, fibroid degeneration seen in pregnancy, right? Now, Just have a look, guys. What we are going to see is, just a minute. Now, in management, what you will do, you will do the conservative management. In case of red degeneration, it will be generally seen in the second trimester of the pregnancy, and they have asked you management, do not perform any surgery, just do conservative management because she is pregnant, she is in the second trimester, you cannot operate now when she is undergoing red degeneration. You just have to go for conservative management. Now coming to the management of the fibroids. Surgery for symptomatic fibroids, it is myomectomy or hysterectomy. You already know. Now, medications for symptomatic management. One is to reduce blood loss. You give the progesterone, then you give the OCPs and tranexamic acid. You have to reduce blood loss, right? Now, fibroid size reduce करने के लिए what will you do? You will give ulipristal, right? Then you can give mifepristone also, and estrogen and progesterone reduction can be done. Amenorrhea. Important topic that we are going to discuss is amenorrhea, guys. Now, have a look here. Amenorrhea, what is the definition? It is absence of menstruation. You already know. Primary amenorrhea, no menstruation when the female has reached up to 16 years of age. Suppose if the female has reached 16 years of age and normal secondary sexual characters have already appeared, then it will be called as amenorrhea. In another female, if she has not attained secondary sexual characters, that means the breast and the other features she has not attained, then if she is 14 years of age, then it will be categorized as primary amenorrhea. So understand, two age groups. 14 years for the female without the development of secondary sexual characters is primary amenorrhea, right? 16 years for female with secondary sexual characters is primary amenorrhea. Both the conditions, I hope now you can remember. Just come here to the secondary amenorrhea. What will you see? There will be cessation of menstruation for 3 consecutive cycles. Simple. In secondary amenorrhea, where does it happen? Most common cause of secondary amenorrhea, it is the pregnancy, right? In pregnancy, it is the most common cause of secondary amenorrhea. What is happening? Amenorrhea will be there for 3 consecutive cycles or 6 months in continuum, and in a woman who has previously menstruated. Secondary amenorrhea. Now, we are looking here at different disorders associated with primary amenorrhea. Different diseases, all are high yield MCQ points we will be covering here. Please be attentive. Most of the diseases we will cover here itself. So, cryptomenorrhea, we have discussed. In cryptomenorrhea, what will happen? You know, cyclical pain every month, right? Menses will not be there. Why? Because the hymen is imperforate. Hymen is imperforate. So what will happen in cryptomenorrhea? The female will menstruate, cycle will be there. When you will examine the vagina, you will find bluish hymen. On examination, you will find bluish hymen. Okay, guys. Now, the genotype or the karyotype of the female will be normal female 46XX. You don't have to do anything. You just have to give cruciate incision on the hymen, right? And the female will start having menstruation. She is having menstruation, but since the hymen is imperforate, the blood is not coming out. Important sign, how will you examine? Just look in the PV, you will find they will write bluish hymen. That is cryptomenorrhea or hidden menstruation. Mullerian agenesis, you already know Mullerian agenesis. What is happening? Female is normal. Her chromosomal structure is 46XX, but there is no formation of the Mullerian duct. And I will tell you, Mullerian duct and the Wolffian duct, you already know. Wolffian duct leads to the formation of male genitalia in the embryology, and Mullerian duct leads to the formation of the female genitalia or internal parts of the female genitalia. So if there is Mullerian duct agenesis, what will happen? The female will be unable to make the Mullerian duct or the uterus and the other parts. So if uterus is not formed, there will be no menstruation. Very simple in the Mullerian agenesis. Now, coming to testicular feminization syndrome, what is happening here? Here in testicular feminization syndrome, actually the child is having the genotype of 46XY. Understood? And he is having testis, but the testis is undescended. And what is happening in testicular feminization syndrome? The external genitalia will be of a female, right? He will have the external genitalia of the female, but the gonads of the male, and the genotype will be XY. Done. Now, breast and pubic hairs will be present in the testicular feminization syndrome. We have discussed all the important causes of the primary amenorrhea, right? Now, Tell me guys, the one question I will ask you, that whether a patient of Mullerian agenesis, if she wants to conceive a child, can she conceive a child or not? Can anybody answer? A patient of Mullerian agenesis, can she conceive a child or not? So yes, she can conceive. How? Via assisted reproductive techniques, because she has a viable ovary. Her genotype was 46XX. She has viable ovaries. So the ovulation can be induced by giving the drugs. Just she is not having the uterus. So she cannot keep the child in her womb. But yes, we can take out the ovum, extract the ovum, and by assisted reproductive technique, she can conceive a child. Right? Now, just have a look guys, what we are going to see here, the difference between Turner syndrome and Kallmann syndrome. Two very important syndromes that they have asked you. Now have a look. In Turner, you already know the genotype is 45XO plus XO or 46 comma XO. Both the things is same. Now, what will be happen here? The uterus will be hypoplastic. Secondary sexual characters will be absent. They will give you a photo of the female. She will having short stature, webbed neck, right? Ovaries will be streak, degenerated ovaries. In the ultrasound, they will appear like streak ovaries, 45 exokaryotype, right? This is the example of Turner syndrome, right? Short stature, webbed neck, I have told you, shield chest, and heart disease is present. Heart disease most commonly present is bicuspid aortic valve and coarctation of aorta. Coming to the Kallmann syndrome, what do you see? In the Kallmann syndrome, what do you see is, here you have female with primary amenorrhea. Listen, Turner and Kallmann, both the female will have primary amenorrhea, but apart from that, Kallmann syndrome mein, there will be absence of secondary sexual characters, right? Along with that, uterus will be present in the Kallmann syndrome. The genotype or the karyotype will be normal in Kallmann syndrome, that is 46XX, right? Height and everything others will be normal in the Kallmann syndrome. But just a minute, guys, excuse me, guys. Just a minute. Now, have a look. What we are going to discuss, one more thing, and two important syndromes we will discuss, very important previously asked topics. Listen to me very carefully. One is the Kallmann syndrome, I had just and other is the Carter-Jenner syndrome. Okay. Now, just a minute, guys. I am having call. Okay. So now, what is going to happen in the Kallmann syndrome? What you will see, and Carter-Jenner syndrome, what will you see? Tell me, guys. In Carter-Jenner syndrome, there will be triad. There is generally ciliary dysfunction. So due to ciliary dysfunction, in Carter-Jenner syndrome, you will find what? There will be, the puberty will be delayed, right? And apart from that, there will be reproductive abnormalities, infertility will be there, olfactory abnormalities will be there, systems will be involved. Not only that, right? In Carter-Jenner syndrome and Kallmann syndrome, can you recall the difference? Guys, just a minute. I'm having call. I'll just write and indicate to you. Important PYQ point we will discuss, because they have been asking this PYQ. Carter-Jenner and Kallmann. Carter-Jenner syndrome and Kallmann syndrome difference. Very frequently they have asked. So in Carter-Jenner syndrome, you will see there is respiratory problem, right? Ciliary dysfunction is there, right? So there will be infertility history, and there will be, because there is ciliary dysfunction, there will be respiratory tract infection. So, and respiratory tract, recurrent respiratory tract infections, chronic infection, and also history of bronchiectasis. Bronchiectasis, two disorders, Kallmann and Carter-Jenner, both are associated with infertility. Listen to me very carefully. In the Carter-Jenner, there will be ciliary dysfunction, respiratory problems, chronic respiratory infection का history मिलेगा, triad मिलेगा, bronchiectasis मिलेगा, right? And now you will have seen, and the sperms and the infertility will be there, right? Now come and have a look at the Kallmann syndrome. In Kallmann syndrome, there will be delayed puberty, right? Infertility will be there, and apart from that, there will be symptom of anosmia. Just have a look. Delayed fertility, infertility, and anosmia. These three features, Carter-Jenner, Kallman syndrome. Understood, guys? Anosmia, delayed fertility. Just go for the Kallman syndrome. In Carter-Jenner, we have discussed, right? Ciliary dysfunction, bronchiectasis, recurrent respiratory infection, over. Come here. Coming to one more syndrome that they have asked you is Asherman syndrome. In Asherman syndrome, what you have to do? Listen to me very carefully. It is just the development of intrauterine adhesions due to recurrent dilatation and curettage. Suppose somebody went for abortion, medical termination of pregnancy, right? Or had an abortion, then dilatation and curettage was done. And due to recurrent dilatation and curettage, in the postpartum period, there can be formation of adhesions and synecdoche in the uterine tissue. That can lead to Asherman syndrome. Now, what is going to happen? In the clinical presentation, you will see decreased or absent menstrual bleeding will be there, right? Hypomenorrhea or amenorrhea will be there. Investigation of choice here will be hysteroscopy, what you will do in the Asherman syndrome. For the management, what you have to do? You have to do hysteroscopic adhesinolysis, right? After that, you have to do intrauterine device insertion, right? IUCD insertion. Now, estrogen and progesterone therapy you will have to give for the Asherman syndrome, very commonly discussed. There will be history of frequent dilatation, curettage, formation of synecdoche and adhesions. Treatment, nothing. Hysteroscopic adhesinolysis, you will have to break the adhesions. IUCD insertion you will have to do, and estrogen and progesterone therapy for the management purpose. Over. Dye they will ask you for the evaluation of Asherman syndrome, that is uses urographene dye or radio opaque dye, very commonly. Cannula, they have given you one pencil like metal cannula, big cannula, that is the Leach-Wilkinson cannula. They will give you, that is used for inserting the dye, urographene dye, and then you examine. Just have a look here. Now, if they give you a history of secondary amenorrhea and there is failure of lactation, suppose they give you that patient was pregnant and she conceived a child. After conception, what happened? She stopped having lactation. What will you suspect? Classical history of Sheehan syndrome or empty sella syndrome. What will happen? It is a complication of postpartum hemorrhage. See, after delivery, sometimes female have excessive bleeding. Due to excessive bleeding, there can be decreased blood supply to the pituitary, and there can be necrosis of the pituitary gland. Due to necrosis of the pituitary gland, the sella turcica or the cavity where the pituitary gland is resting will appear empty in the scans, in the radiological scan. That is why it is called as empty sella syndrome. Now, if there is no pituitary, there will be no secretion of prolactins, right? And no secretion of prolactins, no formation of milk. So there will be amenorrhea. And amenorrhea will be after the delivery, that is postpartum amenorrhea ka history, right? Lactational amenorrhea as well as menstrual cycle will be lost, lactational failure will be there, right? Postpartum lactational failure as well as amenorrhea will be there. Both the causes indicative of Sheehan syndrome or empty sella syndrome. I hope I am clear, guys. Now, treatment, you just give cabergoline and dopamine agonist, right, guys? Now just have a look at the emergency contraceptives. Emergency contraceptive, last slide, guys. We will be discussing it and we will be finishing it. Emergency contraceptives, levonorgestrel, you already know, 1.5 milligram dose. You give single dose. Nowadays you prefer. Earlier you used to give 0.75 milligram 12 hours apart. पहले देते थे 0.75 milligram 12 hours apart, right? अब one single dose of 1.5 milligram levonorgestrel is given. Drug of choice, generally most preferred emergency contraceptive pill, right? Now, copper IUCDs, they are the gold standard. Why? Because they can be used up to 5 days. Ulipristal, you know, selective progesterone receptor modulator it is, right? SPRM, 30 milligram per oral within 12 hours you have to give. Again, ethinyl estradiol, you know, the dose, USP regime, 50 microgram tablets, distributed 2 tablets stat and 2 tablets after, separated by a time of 12 hours. 12 hours apart, 2 tablets before, 2 tablets later. 50 microgram USP regime, you know, this is for the COCPs. If you want to achieve emergency contraception with the help of COCPs, you follow the USP regime, 50 microgram, 2 tablets, 12 hours apart. Right? Discussed. Mifepristone, RU486, not very important. For you guys, it is not important. No need to remember the extra. Just remember this one. Levonorgestrel, drug of choice, most commonly preferred. प्रोजेस्ट्रॉन एनालॉग है, राइट, 1.5 मिलीग्राम सिंगल डोज, अर्लियर 0.75 मिलीग्राम 2 doses, copper IUCD gold standard effective for 5 days, right, levonorgestrel effective for 72 hours, ulipristal we have discussed 30 milligram per oral 12 hours, ethinyl estradiol or COCPs, if you give COCPs, USP regime you will follow for 50 microgram, 2 tablets 12 hours apart, again 2 tablets, done, finished guys. We have revised most of the important topics of obstetrics and gynecology. Most of the important PYQs and PYTs we have covered. We have not missed anything. I hope the most of the asked questions, question wise approach we have, took and discussed every topic that has been asked previously, and all the important points that were asked we have covered. Most of the topics for FMG examination and some of the topics for NEET PG examination also we have covered. So guys, thank you, thanks a lot, and it's over now.